Russia could not support the Russian HIV strategy, the global HIV strategy. We now have a public strategy on contradicting the spread of HIV infection till 2030. First and foremost, we focus on access to testing and therapy, and also access to prevention. We believe that our strategy is feasible and it ought to be beneficial in our fight while we're combating this disease. Now let us get down to the key point. Now we can hear Masudera, the special representative of General Director and the regional European. Please, Masudera, the floor is yours.
Вас не слышно.
Unfortunately, we cannot hear you. We cannot hear you. We cannot hear you. We cannot hear you. Unfortunately, we cannot hear you. Now the technical organizers will streamline our program. Unfortunately, we cannot hear you. Now let us get down to the first presentation, and then the floor will be yours, and we will keep working on it. Sorry. Natalia Ladnaya, the senior researcher of the Institute of Epidemiology. It is dedicated to prevalence of COVID-19 among HIV patients in Russia and influence of the COVID-19. Good afternoon, dear Mr. Chairman, dear colleagues. We're delighted to see you after this time period when we could not see one another in person. Now we can communicate with one another. Our session is dedicated to two topical issues related to our conference. Could you please show us the presentation of the first speaker? And our presentation is dedicated to the research which was conducted in 2020. We studied prevalence of COVID-19 infection among HIV patients and the influence of the COVID-19 pandemic on medical service provision for HIV patients. It was conducted by several organizations. Here you can see the names of my co-authors. It is a comprehensive author group. They are representatives of a few organizations, the Central Institution of Epidemiology of the Rospotrebnadzor, and it was also supported by Rospotrebnadzor and UNAIDS. I have already enumerated the objectives. There is also one optimistic divergence. Let me highlight that we believed that HIV patients would never be affected by COVID-19 because we tried to treat the patients, and we believe that there would be a viral competition, but our hypotheses were not confirmed. It was an epidemiological research. When we analyzed epidemiological and clinical information, we collected data while carrying out anonymous surveys in the internet. This method was efficient, effective, and safe. And we also wanted to get the information on the patients who were HIV infected. Not only did they refer to medical institutions, but they also referred to some other organizations. These publications were dedicated to hospitalized patients, but not all the patients with HIV were hospitalized. Still, they could suffer from COVID-19. Our patients with HIV told us that they had suffered from COVID-19, and then they referred to our counselors, and then we found out the information on COVID-19. And this study was conducted in 2020, and we also conducted statistic processing. There were 590 people who participated in it, and 590 people suffered from HIV, and 262 people were HIV negative. Some of our respondents have never participated in HIV tests, but we excluded the data of the comprehensive analysis. And women prevailed in these three groups of the survey. It was the fact that differed our sample from the population, because normally men prevail in this group, in this PLWH group, and of the PLWH were treated. First and foremost, we studied the impact of COVID-19 on medical assistance. People were concerned with it. WHO and UNAIDS were concerned with it, and our countries also were concerned, and they published some announcements and reports. They addressed the patients. Still, we see that most of our respondents, over 70%, didn't have any problems while receiving antiviral drugs, and most of them were supplied at home. And the employees of NGOs and HIV centers, some of them mentioned some negative changes which affected the work of HIV centers, and some of them could not take these drugs, these antiviral drugs, because they could not receive them in HIV centers. Sometimes the reserves only included the number of drugs which was sufficient for 1 month, and it was not sufficient. And some of them could not take the drugs against tuberculosis because they didn't have access to them in the epidemiological centers. We also conducted the study on COVID-19, those who were HIV negative, and some of them were tested for coronavirus infection compared to PLWH. The odds ratio was 2.8, and our kinds of studies were also different. Our PLWH were tested in PCR activities, and HIV negative people were tested for antibodies to HIV. Those who have undergone the tests for coronavirus identified the markers of coronavirus. In summer 2020, 23.5% of our surveyed people received positive results of the tests. There were much more people compared to those who were HIV negative. The odds ratio was 4.7. The doctor has diagnosed them with COVID-19, and they told that in 17% of cases, it's 7 times more than the numbers among HIV negative patients. Some of them told them that they suffered from it, and that then they communicated this to HIV centers. Experts who were treating HIV infections were not aware of coronavirus infections in patients. The risk of being infected with coronavirus was similar in terms of self-esteem. It was estimated as 5 out of 10. They could be infected with coronavirus, but HIV positive people did not mention that they used different precautions and masks compared to HIV negative patients. It means that they faced high risks. The ones who lived with HIV had some symptoms which were similar of COVID-19 symptoms. It was related to presence of comorbidities and concomitant diseases. They were often observed in HIV negative people, and it is true. If there were some symptoms reminding of COVID-19, many patients with HIV did not refer to medical institutions. They suffered from this disease at home. Some of them treated the COVID-19 infection on their own without addressing medical workers. Here we can see the characteristics of the PLWH, and their characteristics differed from the main group because there were much more men in this group. This corresponds to the data of the general population. Men are often affected by COVID-19 infection. Some of them have been living with HIV for a long time, although the vast majority of them received antiretroviral therapy. Still, their immune system was compromised, and some of these patients suffered with immune deficiency, but it was not that severe in the majority of these people. Still, they were affected by COVID-19. We're also concerned with the fact that 41% of PLWH have undergone COVID-19, could not tell anything about their viral load during the last research. Thus, we are planning to conduct the second research in order to find out what it could mean, whether they had viral load or not, or they did not pay attention to it. Perhaps they do not understand these issues. As for the most common symptoms, we can see body temperature increase, loss of taste or smells. Having analyzed the ways of contagions, we understood that they were infected by their nearest and dearest, by their family members, partners, husbands, wives, and children. There are some limitations to this study because we can see the sample shift. There were more women involved in it. Maybe some people who haven't faced COVID-19 did not participate in this study. Still, we should take precautions in order to eliminate or at least lessen the sample shift. But here we can see the summary. Among the participants of our study, HIV people were more affected to coronavirus infection compared to the HIV negative respondents. Most respondents who were PLWH did not have such a lot of symptoms of COVID-19, but they were not often tested for COVID-19, and they also rarely referred to medical institutions. HIV negative patients suffered from different diseases of gastrointestinal tract and of kidneys. They could cause some difficulties while diagnosing the disease. We can see the negative impact of the pandemic of coronavirus on medical assistance in HIV infection, but this impact was not that significant compared to our expectations. 1/3 of the respondents told us that they had faced difficulties, but most respondents did not face these challenges. The PLWH among respondents were primarily men, and they had been living with HIV for more than 10 years. They took ARNT, and they did not have any severe immune deficiency, but they did not feel that good due to the long HIV status.
Большинство из них имелся объективный.
The overwhelming majority had the risk of infection due to a multitude of sources for infection of COVID-19 at the level of their close ones. There were more than 5 to 10 bodies of theirs to have COVID. So we have to recommend the improved measures for prevention and vaccination first and foremost, as well as the early diagnostics for treating of COVID-19 for HIV people. And so with regard to that conclusions, we would like to once again repeat our tests, thus providing longevity for those having COVID. I think the questions will be put in a written form. Or right away, maybe you have some questions from the audience. Just one question, and the rest will be provided in a written form. Sorry, I can't hear the question. There is no microphone. Sorry, the question cannot be heard. There is no microphone. As to our survey, we didn't have a chance to study it, so we had to interview respondents live. But there were some who passed away, and I did have a chance to tell you about that. And our territorial centers for AIDS already have some studies of that sort, and already we have a list of theses showing high mortality rate from COVID-19, those who already have HIV. Let me cite some numbers for the pre-Ox Federal Okrug. These are absolute numbers, not the generated one. And we've been collecting this data within our okrug, and proceeding from that data, we had HIV, COVID, we had 834, and outpatient clinic. Actually, as to the clinic, they had more than 1,200 had to undergo that particular treatment, but the mortality rate was pretty low, only 29 people. But these are our respondents, but some of them never ever resorted to the medical aid out of this list. Masoud Dara, and is it possible now to communicate with him? Couple of minutes, yes, and there's the next report to come. Mrs. Beleva, the senior fellow of Rospotrebnazol knee Epidemiological, and they are going to dwell upon the status of the medical staff. Will you please download my presentation? Any problems with my presentation? Thank you so much. Dear colleagues, esteemed guests, ladies and gentlemen, thank you for the opportunity to have a say here. And I would like to dwell upon some results of the survey on the peculiarities of the emotional state for medical staff and patients infected with HIV with regard to COVID pandemic, two waves of pandemic. This is an emotional as well as a psychological problem. Proceeding from that premise, I would like to discuss the results of our studies. So who were the parties to that research? The specialists of cybernetics, informatics, infectionists, and we had to study the self-assessment of the emotional status. And we had to address certain questions to our respondents, thus try respond. Which is inherent in the COVID disease anamnesis. And what was the first period for such survey? That was the June last year. And we had a questionnaire, had a vis-a-vis interview, and there were two groups of respondents, medical staff, and the second group are those patients with HIV, which are enlisted into our special ward for epidemiology and the prevention of HIV. The first group encompassed 67 people, mainly females with a higher medical education, located in Moscow and in the Moscow region. And the majority used to be essential workers in the healthcare system. And the second group, the overwhelming majority, were females with the average age of 38, and they had the higher or secondary education, and they had like 10 years of that disease to be inherent, and who actually experience the anxiety first and foremost. Some said that I, on a temporary basis, have the anxiety. Some said that I have it on a permanent basis, and some said that I do not have it at all. So let's have a look at this cross-section of our patients. Sorry. At the profile of our patients, and everything looks more or less fine. More than 50% have no anxiety. Sometimes it is 44, but the first group looks different. They have that feelings by 2 times as lower as opposed to the previous group. But we have the option on the right-hand side, and actually mostly the medical workers experience that anxiety. And we had from this score system from 0 to 10, and statistically we have quite a difference here. And the first group showed 6 scores, but the second showed 9 scores, and the respondents of the second group had a higher indicator. So the group number 1 is keen on the gymnastics, on meditation, on the reading, on hobby, and just listening to music, but it somehow aligns our 2 groups. But if the medical workers statistically resorted to communication, to the support of the microsocium, but as to the second group, at the level of the patients group, we didn't witness this practice. But as to the strategy for adoption, they were more resorting to alcohol, to smoking, to just extra food, and religious. As to the second group, they had religious practices. They tried to appeal to the higher force in case they had some kind of an anxiety. Here we have quite a large spectrum for identifying the strategy. I think it was mostly a humanitarian approach, but nevertheless we were also focused on the mechanism of prevention of those diseases. Some actually use the PPE, thus minimizing their level of anxiety. But if we resort to the means of prevention, to the PPE, it anyway takes not a very significant role in the strategy. Thus, a person may feel more comfortable, more calm, but not within the first group or the second group. That result got to be a predominating one. What were those preliminary conclusions to be provided? So we realized that the medical staff identified some kind of vulnerability and sensitivity and non-adaptive strategies, and they didn't have really some interrelation between the prevention measures and minimizing the level of the anxiety. We didn't see this link. And as to our patients, they actually ousted the anxiety feeling with regard to the COVID infection. And also they had the deficit for communication, which minimized the level of anxiety, and it is more related to the level of stigmatization, auto-stigmatization in that group. And thus it was embedded in their emotional feeling expression. But the pandemics is still continuing, and at the second stage of our survey, we interviewed the same group of patients, and that was the second period, October, November. And we had absolutely compatible groups for the longevity, for gender, for sex, and the only difference was that only 7% of our respondents already underwent the COVID-19 disease. We got absolutely the same instruments at our disposal and same methodology, but some said that they were subject to anxiety, some not, but there was no obvious dynamics visible. But nevertheless, we had an option all the time, always or pretty often. But upon the first interview, we didn't have such responses. As to the first group, we had 9 scores, and for the second group, we had 7 scores. And the results for those statistically significant group have become lower by 0.2. And what are those statistics for the significant levels for minimizing the anxiety level? And actually, we thought about the professional skills adaptation, but in the second survey, we didn't have it. Probably it was all due to the problem of business and extra employment, and we're supposed to somehow clarify it. And as to the religious practices, say they were also minimized, but we had one new trait. The information on the mode for the information to be provided to better conditions for sleep. But as to the alcohol and smoking, these characteristics were still in place. So this is the dynamics as to how to minimize the level of anxiety with due regard to the COVID infection. And so far, we haven't witnessed any dynamics of that sort. And we do not have an understanding as how a person may behave himself and protect himself.
Still, dear colleagues, we are tested. And in the second survey, we asked the following question to our respondents. We used the verbal incentive. We said coronavirus infection, and we asked our respondents to say the first words which struck their minds. It is the association-related methodology. Interestingly, 25% of content was associated with the medical constituent of the problem. The problem is associated with medicine. Still, the proportions are equal. I mean, prevention the same. Masks, gloves, and PPE and also the emotional constituent. Prevention and emotions had equal proportions. Still, these emotions were exclusively negative. Fear, anxiety, panic, overreaction, even death, and irritability. It was an association-related experience. We see both prevention and emotions. Still, they are not interrelated. We should find out where is the connection between these two constituents. We should find the cause and effect link here. I use PPE. I feel safe. I am calm because there is the low risk of being infected. It is an extra motivation to prevention, and we lack it. For this reason, we need communication. We will dwell upon it in the future. We have published the results of this research. You can read it in the 4th issue of the magazine Epidemiology and Infectious Diseases, topical issues. And we also read about dynamic of positive conditions in the 2nd issue. Thank you, Valentina. It is scientific research. Thank you very much. You will ask the questions in the written form. Hopefully, we will listen to Masudara right now. Let us ask our technical Organizers, hear us? Still, we cannot hear you. Can you hear me? Okay.
Dr. Gerovich, if you permit, let me speak at the end, so we have one more talk. I understood. I will listen to the last talk, and if you permit, I will speak afterwards.
Okay.
Буду говорить.
Окей, хорошо. Тогда в конце, да,
Yes.
все-таки, наверное, подведет вывод какой-то определенный. Хорошо. Анна Анатольевна, прошу вас, распространенность SARS-CoV-2, возбудителя COVID-19 у больных ВИЧ-инфекцией, медперсонала, работающих с данной группой пациентов. Прошу. Спасибо.
А можно презентацию?
Prevalence of SARS-CoV-2, the pathogen. Dear colleagues, thank you for giving us a chance to present the results of our study, which was provided at the end of May 2020 until the end of September. This study was conducted by the Epidemiological institution of the WHO. It was conducted by 4 branches. The first case of novel coronavirus infection was registered on the 2nd of March 2020. As far as you know, determining the level of immunoglobulin G contributes to forecasting population immunity, and it allows us to arrange anti-epidemic events. We can see the different groups of the population of Moscow. If you can see the number of people who had antibodies to COVID-19, there were 22% Moscow in summer. 22 patients live with HIV infection, and we decided to conduct a similar research in this population. We're going to assess the prevalence of COVID-19 in HIV patients and medical personnel who contacted this group of people on the basis of identifying the pathogen of SARS-CoV-2. The study was comprised of 2 stages. Then, at first, the informed consent was signed, the biomaterial was collected, and the questionnaires were filled in. Then we analyzed the samples. We examined 150 people. The medical personnel included 20 people who were diagnosed, who were examined for 3 weeks, and there were also 130 patients. Women prevailed among the medical personnel, and men prevailed among patients. Here we can see the criteria of participation in the study. They have to sign the informed consent. They should be over 18 years old. They also medical documents are required, and constant contacts with HIV patients were also there. Was also the criteria of inclusion. The criteria of exclusion were the age younger than 18 years old, pregnancy, and non-compliance with preparation for tests. Biomaterials, biosamples were collected of the larynx and also of the colon. Biomaterial was also collected for identifying specific antibodies of G class. For this reason, we took serum. This slide represents the age of the participants in the study. Medical personnel was 42 years old, approximately at least 29 years old, and 59 years old as a maximum. So HIV patients, the median age was 36 years old, and the maximum was 59 years old. The absolute SD4 lymphocytes values were higher in medical personnel. There were almost 1,200 cells, at least 2,500. As for HIV-infected patients, the median was 639, and there were 1,900 cells as a maximum. This slide represents the characteristics of HIV-infected patients with RLVT. All the women who participated in this study received ARVT. 31% of HIV-infected patients did not receive ARVT because they were recently diagnosed. The medical personnel also suffered from chronic diseases in 55% of cases, and 70% of them were men. The number of contacts over 14 days prior to the study is the following. We see that the medical personnel limited the number of contacts, whereas the HIV patients did not limit their contacts. Thus, HIV men had more contacts than HIV women. Due to the risk of COVID-19 spread, medical personnel in 90% of cases kept working out of home, complying with precautions. 35% of patients were locked down and 5 to 7% kept working from home, complying with the precautions. Over the past 14 days, 45% of medical personnel contacted the people who suffered from COVID-19, and 45% of the medical personnel did not suffer from any diseases. As for HIV patients, we see that in 80% of cases, people did not indicate of any diseases, and some of them have suffered from acute respiratory viral disease. Over the past 3 years, the medical personnel contacted people who were treated due to COVID-19. 60% suffered from acute viral disease, and some of them have just come back from impoverished areas. Some of them contacted those who were treated. 22% had suffered from acute respiratory diseases, and 6% came back from epidemiologically unfavorable areas. Most of them did not suffer from any diseases, while identifying the pathogen of COVID-19 in the smear out of the nose and out of the oral cavity. COVID-19 was identified in one case while examining medical workers, medical personnel. The pathogen of COVID-19 in smear out of the anus was not identified in any case. This slide shows the structure of HIV patients with SARS-CoV-2. All the women with COVID-19 received ARVT. 40% of men did not receive ARVT. There were more than 300 of them. The presence of antibodies to SARS-CoV-2, 5% of medical personnel had them, and 13% of HIV-infected people had antibodies. The frequency of identifying ribonucleic acid of SARS-CoV-19 in the smear of the oral cavity or of the nose was of 4.6%. The presence of Ig antibodies to SARS-CoV-2 in the group of HIV-infected people was 13%, and it was 5% in the group of medical personnel. These takeaways show that we have to comply with precautions in the study groups, and the results indicated. Thank you for your attention. Thank you, Anna.
Thank you so much. And in the general population, we had the statistics as of May 2020 by the end of September. Thank you. Alexey Viktorovich, the floor is yours. He's going to dwell upon some therapy and clinical process for HIV-infected plus COVID-infected people. And it's my honor and privilege to greet you all here, just in person and not online. And probably you've followed the presentation of Professor Lundgren, and it is very close to the contents of his presentation. And indeed, it's worthy to mention then we talk about some conjugated infections for HIV and COVID-19, and it becomes quite clear that for people with cardiovascular system, lung problems, diabetes, so these diseases tend to be more severe. And if you have HIV infection at very hard stage, so you have some kind of an aggravation. And some people think that these data are not available in full. What about the ATR therapy, whether it somehow affects the disease per se, but AIT system actually compensates the immune system, and cells are suppressed, and actually that's how it works, and the situation is balanced. But the question arises whether it's worthwhile to replace the therapy, but we're going to talk about it later. Let's just have a look as to how chronic diseases affect the hospitalization and the hard COVID-19 infection implications, and that should be hypertension, diabetes, cardiac disease, and the chronic kidney disease. As to HIV infected, having this positive and negative patients in conditions of meta-analysis, the chances are by 1.9 times are more vulnerable. But as to ATR, they are not always visible by the medical staff, and actually they may already become a part of this disease treatment already in the hospital. And we have pulmonary tuberculosis masquerading as coronavirus disease 2019 in the HIV-infected individual with advanced immune suppression. And in a monthly period, we had the ART break due to lockdown. And what do we finally have? The COVID-19 already had this infection stated, but it was he passed away. But finally, the coronavirus has not been actually confirmed. What are those antiviral medications? Remdesivir, Maraviloc, Favipiravir, Ribavirin, Sofosbuvir, Camostat. For many years, we have been activating it. Anti-parasitic ones, nitazoxanide, ivermectin, and antibacterial, ciprofloxacin, and retroviricin. But we have some kind of a cautious attitude to this particular drugs. But the Ministry for Healthcare already on a 10th time revising these methodological recommendations. So version number 10 presupposes that remdesivir antiviral Venpiravir inhibitor for virus RNA in here. Lopinavir is excluded as the protease inhibitors, but where do we use them? How do we administer them? We actually use some inhibitors for coronavirus, and it was a very authoritative opinion of the Nobel Prize winners, Professor Montagnier, who was awarded for this coronavirus detection methodology. And we actually used the interferon beta ribavirin and have a look at the dynamics of this disease with valid cytokine. And the red line shows the triple therapy, and there was an effect as of the 6 days. 6-day, but it didn't affect to a large extent the coronavirus, but for interferon with ribavirin gives quite a reasonable result. Omifenovir, it is also included in the list of recommendations for flu treatment in Russia, China, and CIS countries, but so far we don't have the clear-cut survey on that score. Parafirivir, it has the after trial a list of results, and what have we seen by the end of the day? 406 were screened, randomized 400, and as a result, 5-epivir within 7 days showed the distinctive difference as opposed to the standard medication, which was administered for 10 days. And as to the lethal takeaway, we haven't got such survey. The effect is in place, but it's not so marked. We had 286 patients, 2/3 got parafiravir, and 1/3 got another therapy. And so these are just outpatient clinics surveys. They were not hospitalized. And as a result, the best clinical result was very visible for the 7th day. And the elimination of virus constituted 70% as opposed to 57% for the 3rd day and 81 as opposed to the 6th day. And so virus worked more progressively for favipiravir. Chloroquine hydroxy. In the Russian really, we still have it, but the Americans excluded it 100%. And they had the standalone survey bringing about a higher toxic effect, higher than the efficiency of the process. Azithromycin, this is the antibacterial drug, but it has also antihistamine effect, but it doesn't have a clear advantage. And it's compatible with the list of previous medications. And we actually had non-nuclear inhibitors, especially azithromycin and haloxib. And it may bring about the cardiovascular problems. Antibacterial therapy. And this is the last recommendations of the Ministry of Healthcare. And it says that the overwhelming majority of patients with COVID-19, specifically when the disease is not that hard, are not in a great need of antibacterial therapy. Remdesivir. We made 2 serious research, and it was published in the New England Journal of Medicine. It was the American survey, and actually we had the placebo group, and 11 days people stayed in the hospital and administered remdesivir, and 15 days for placebo. And it was there were 159 patients, 539 treated with remdesivir, 521 for placebo. And actually, Americans tend to say that it is the only medication which brings about some kind of an efficiency with regard to the therapy. genic therapy for COVID-19, tocilizumab, baricitinib, leronlimab, and actually we have to be cautious as to these particular drugs, as it minimizes the immunal status and brings about the probability of bacterial infections, and therefore we have to be really cautious in selecting these diseases. As to the recommendations of the Ministry of Healthcare, it is really a very harmful one for TB. And as to HIV infections, we know that TB tends to be the secondary infection to emerge. And once this drug is administered, it could be done with due regard to 100% exclusion of TB emergence. And hereby, we really have to think twice in selecting this particular medication. We have NSAIDs which may cause increased AC2 receptor expression. However, this is no data in the patients for MERS, SARS, and COVID. But as to methyltozolone and methylprednisolone, it showed quite distinctive results for HIV infected. And how do we combine these antiretrovirus medications? And this is the Polish experiment, and it is here on the site, www.covid19druginteraction.org. This is their site, and I have enlisted quite a number of preparations, chloroquine, also on cemosicin, and they are somehow conjugated, some not, and we have chlorophyll, but we do not use it this way. And so azithromycin, chloroquine, and favipiravir, remdesivir. So we have to first identify the efficiency with regard to the electrocardiogram. And that is the result for the 1st of March 2021 for 85 patients, for male 68, for female 18, and the average age is about 40, and they had the IRT therapy actually, all the patients haven't yet identified RNA for HIV, and they had the inhibitors in integras, and some didn't use this IRT. They just came to visit us as a part of their consultancy services. And actually, these are patients who told us that they actually underwent through COVID-19. They were included in that particular survey. And what are those conjugated or related diseases? This is hepatitis, pancreatitis, and
Pancreatitis, diabetes mellitus are concomitant diseases. Still, they are monitored. The COVID-19 diagnosis, it is diagnosed in 45 patients with a positive PCR. Antibodies were were identified in 45 people with IgG antibodies. It was based on CT. Still, it may be doubtful. The moderate case was diagnosed in 22 people. The mild one was diagnosed in 63 people and 2 patients. Some of the patients did not refer to the diseases, and then we diagnosed them when no one has not done it yet. Still, we see such a significant difference in registration of COVID-19 infection in the population, and more antibodies are identified compared to those who have suffered from COVID-19. 2 patients have suffered from COVID-19 twice. In one case, it was mild. In the second case, it was moderate, but both cases were confirmed. They were confirmed by either PCR or antibodies. Here we can see the signs and symptoms. There were no symptoms in 9 cases. There were mild symptoms in 8 cases. They couldn't be identified without any questionnaire. The body temperature rise was identified in 63 patients, and there were also such symptoms as dyspnea, headache, laxity, and CT was conducted in 38 patients, and there was only 1 case when the lungs were compromised severely. They had the mild progression of COVID-19. There are 9 patients in hospital. In some cases, it was moderate, and in 2 cases, it was mild. There were 3 patients without antiretroviral therapy. There were 14 cells in 1 patient, but he had pneumocytic pneumonia in history. Thus, these infections were observed. They got antibacterial therapy. It was in summer last year. And there were also such kinds of patients as anticoagulants and corticosteroids, and the ones who were treated out of hospital. We can see the same patients. 2 of them got remdesivir, and 7 of them received anticoagulants. Drug interactions are represented. You can see hydroxychloroquine, which contributed to prolonging the QT interval. EFV was used with azithromycin, but they did not interact. And the adverse event related to heart rhythm was observed, and there was also 1 patient with a mild progression, and no coronavirus infection was diagnosed. This patient has been diagnosed with HIV. He has been suffering from it since 2000. He received tuzovrin. The number of cells is 690, and then CD4 cells. The load is not identifiable. So in September last year, the patient's wife was diagnosed with COVID-19 of the nasopharynx. The lungs are compromised, and she was treated at home. His smear result is negative. I mean, in the patient himself. He had a runny nose for 2-3 days, but he still could smell everything, and he kept working all the time. A month later, in October, the patient undertook the total blood count for antibodies. The level of AG antibodies was higher. It was 2.5 times higher, and it means that the patient has suffered the asymptomatic COVID-19. We can also see the diminishment in the CD4 cells, and the viral load was not identified 4 months later. The cells recovered, but there was no viral load. There was no replication of the virus. In conclusion, let me highlight that the progression of severe COVID-19 in HIV patients is higher than compared to the rest population. I mean the patients with HIV and ARVT. And some experts say that the number of the cells was minimal in the patients. The severe progression is identified when comorbidities are diagnosed. The death risk in the HIV patients is comparable with the risks in the general population of the patients with COVID-19. There is no coronavirus in some patients. There's no data of effectiveness of antiretroviral treatment for prevention and treatment of COVID-19. Still, the patients received the same RVT on the same regimen. It is considerable, and it also depends on the presence of medical product interactions. This study has some specificity. There were no lethal outcomes. Some of the patients did not suffer from severe progression, and there were no concomitant diseases. Most of them received RVT, and it was efficient. Thank you for your attention. It was effective. Thank you for your attention. Alexei, there is one question. Let me identify that whether most patients received inhibitor integrase. Is that true? Yes, we have approximately 1/3 of integrase inhibitors, and a little bit more than 1/3, and the rest received another kind of treatment. There was a lot of inhibitor integrase cases. It is observed these patients participate in clinical trials, and it is comparable with dolutegravir. Our patients receive the therapy on HIV infection. They refer to us, then we survey them and identify whether they suffer of COVID-19 or not. Yes, this sample is random. Thank you very much. The next presentation is evaluating awareness of HIV patients about the COVID-19 prevention during the pandemic, to be presented by Ulyana Kuimova. Please stick to the time limit. Good afternoon, dear colleagues. I will not take a lot of your time because I was asked not to do it. When we drafted our short study, I remember that our colleagues and I were in a hurry because it seemed to us that it was about to finish and no one would be interested in it. I exaggerate, still I did have similar thoughts, but we see that this process is endless. I mean, the coronavirus infection, this theme is still topical, and the methods of COVID-19 prevention are also topical. You can see them on this slide, the precautions and the methods of prevention of COVID-19 recommended by Rospotrебnadzor. And our idea was studying whether our HIV patients were aware of these rules or not, whether they managed to comply with them in real life or not. The objective of our work was to study changes of concepts of prevention of COVID-19 and scenarios of prevention of patients who are HIV infected while preventing COVID-19. We conducted a survey of 160 patients. The visits of these patients were planned, and the visits were current. They participated in surveying. The questionnaire was designed for this study, and it was voluntary. No one was compelled to participate in it. The patients agreed to participate in it. There were 2 stages of surveying. We have already mentioned it, the beginning of the session. It was part of the same project. We decided to carry out this survey in the first wave of the pandemic. And we conducted this study in May and June 2020. We questioned these patients. It was still topical because we still suffered from COVID-19. Then we repeated this work in October and in November. 81 people participated in the second study. These groups are comparable because there were 79 people in this study. Primarily men participated in this study because there were more men among respondents, and they outperformed women in both groups. They had higher education, our centers. I mean, young people, the age median was 38 years old, and it was 40 years old in this second group. And the number of the respondents who have been affected by COVID-19 was 2 in the first group, and there were 6 of them in the second group. And the median of life expectancy with HIV was 10 years in the first group and 9.5 years in the second group. We were interested with the methods of preventions of which our patients were aware. And we also wanted to find out which methods they used. And these indicating questions helped us of which methods of prevention of COVID-19 are you aware, is the first question. That's what we received as a result of this 2-stage questionnaire. PPE were prevailing in both groups. There is no significant difference. It was the most popular response. There were also some disinfecting means. They were not mentioned to such an extent in winter, and in autumn still they were topical. A limitation of visiting the crowd events, social distance, and self-isolation. Let me dwell upon self-isolation. It was recommended to us, especially in summer and in spring. In 17% of cases, said that self-isolation was important, but this answer was not frequent, but they stopped mentioning it later. There were only 6 of them later. This due to the fact that it is statistically significant. We believe that young people prefer a healthy lifestyle. They are only 40 years old. They work in most cases. Perhaps it correlates with this answer. I will show on the next slide that they did not adhere to this method of prevention, and they did not focus on it. Maybe they were not aware of it completely, because we studied awareness. Enhancing the immune system was also related to methods of prevention of COVID-19. It was also mentioned, and antiviral drugs were also mentioned. In the first group, no one mentioned them, but later on people started mentioning it. There were 3 people in this group. They believed that antiviral drugs could contribute to protecting them, to preventing them. In the course of the questionnaire, some patients said that antiviral drugs could protect them. They believed in these drugs regardless of the doctor's statements and the scientific publications. They were absolutely confident. Sometimes it should help, because it was mentioned by those who had not suffered from COVID-19. Controlling the psycho-emotional condition and the health condition was also mentioned in some cases, but no one mentioned sports and walking outdoors. Maybe it was related to limitations in summer and in spring because it was banned, but later on, when the system was attenuated, the patients believed that it was necessary for protection. And the last one is other factors. There is a group of patients who believed that no prevention methods could be used in some cases, in these cases. Although there was lots of guidance given to the patients, they still believed that no methods would be used by them because they were not aware of them. It may also be related to insufficient information. Maybe this information was not spread to everyone, or it was not presented in a proper way. Maybe this reaction to the answer to the question was negative because people were exhausted and they were protesting. It was refusal and rejection of the challenge. Still, let us focus on it. Let me remind you that we also decided to find out which methods of prevention could be used by our patients, and they were used by these patients. Here are the answers we received for this question. We see that PPE are commonly used, and they were increasingly used in winter and in autumn. They also mentioned hygiene. Disinfectant means hygiene was not that common later. Still, the difference is insignificant. Disinfectant means are comparable. Later, people started going to crowded areas. Social distancing was equal in both cases, in both groups. Here we can see the self-isolation. It is also related to awareness, but this method became twice less common. Maybe it is related to the fact that some restrictions were lifted in summer. People had more room and more freedom and more opportunities for leisure time. Some people started going to work instead of working from home, and young age implies various activities. Not all the young people can adhere to self-isolation, to lockdown, in order to prevent the coronavirus infection. Enhancing the immune system was also similar. Still, they mentioned that they enhance their immunity. And only one person mentioned sports and walking outdoors. And a small group of people said that they did not use any methods of prevention or used some other methods of prevention. In fact, it should be related to the psychological response, the avoidance of this topic, and the fact that people were exhausted while listening the information about this problem. This is mentioned, and it is related to the mood of people. Invariably, all these factors are important, such factors as awareness of the patients and the methods of prevention which they used. We would like to support our patients whom we have been managing for many years, and we also included the following question in the questionnaire. Which assistance would you like to receive in this case due to COVID-19 infection? Not all the patients answered this question. Some of them avoided that. Still, there was a response that they did not need any help. Some people need financial incentives because people had some personal problems. Also, let me highlight that a great deal of people needed medical assistance. Some of the responses were really important. They said, in case I fall ill, in case I'm infected, I would like to receive this and that. Some people were anxious about it, and there were not many patients who had a history of coronavirus. Some of them still suffer from it, but at that time there were not many patients, and they were afraid of it. And they were afraid of living without antiretroviral therapy. Sorry. Now, to sum up, let me accentuate that we did not receive any reliable and accurate differences while conducting surveying in 2 stages. Still low awareness of our patients in terms of coronavirus infection takes place.
But we have to take into account the mere fact that not always we are familiar with the prevention methods, and actively we got consultancy on the vaccination issue. And hereby, we have to have a clear understanding as to what our target groups are and how to initiate a dialogue at their level. And I focus my attention on that as we have an inquiry for providing the medical aid first and foremost. And so let's support our patients in such a painstaking period with some minimum losses. I don't know why my presentation is not yet here. And the last slide is here, but we can do many things all together and not just alone. And this is a teamwork, and I would like to cordially thank my colleagues in the participation in that particular work. Thank you for their for your kind attention, and you are very much involved and enthusiastically into that particular process. It's a very interesting presentation of yours, and Alijan Salif is going to dwell upon the situation in Tajikistan Republic. He is the Deputy Director of GORC SPID. Ladies and gentlemen, dear colleagues, dear attendees to that conference, my presentation is not fully dedicated to the studies and surveys, but I'm going to dwell upon the realistic situation on the coronavirus situation and opposing the HIV/AIDS in the Republic of Tajikistan, and it affected to a large extent back in April the entire system of healthcare, and we do sense the COVID-19 situation onto the entire situation with HIV/AIDS. And we are abiding by the ruling of all the declarations identified here at the national level. As of 1997, we've been adopting the national strategy on the opposing of HIV and AIDS. And the seventh national program was enacted just recently till the period 2025. And the key objective of the new program is the conjugation with the international global goals, and that is a part of the UN program for combating HIV/AIDS. That is what we had as a statistic for testing for HIV in the Republic of Tajikistan 2016-2020. More than 1 million had been tested, and it has a very wide spectrum for testing, but due to the coronavirus and due to some limitation measures in 2020, we had by 21% less people than in the previous period. And we actually had to identify the HIV. And by the new parameters, we have by 80% less infections than in 2018. The level of or the factor for identification of those tested tends to be the same, more or less, when it was 0.2% for country-wise. And with regard to the international strategy, Tajikistan is building up the material base for HIV/AIDS combating. And already we had some new cases identified in 2020. We covered about 89% of those infected, and it was much more than in the prior period, before the identification of and discovery of COVID. We work in cohesion with a number of international organizations, and quite a number of actions were undertaken to combat HIV/AIDS plus COVID. And we had the hotline opened. Also, we disseminated special drugs within 6 months, as well as the psychological support and online Q&A. And all these actions were aimed at the prevention of COVID and also supporting patients at this level, those HIV/AIDS infected. Within that period of time, we also provided aid to our compatriots abroad, and that was a mission of non-commercial organizations plus the Russian organizations, and thanks to their aid, they were provided specific treatment in some adjacent countries, and it has become the routine practice. But within the period of mass dissemination of coronavirus, 4 mobile comprehensive groups were operating, and that was allocated by the Russian Federation and for those labor migrants and their families. And we identified some suspicious cases for COVID, and then they were relocated to a specific hospital, and within a short period of time, they were provided with PPE, some information and educational documents, and also there was a special we undertook special actions in order to reach those who were located on a remote basis in conditions of 100% lockdown. And neighbors within a certain period of time couldn't see even their neighbors, but out of the blue, we had the clinic deployed in that remote conditions with all the medical equipment, with all the specialists, with all types of medical staff, and these services were provided to a number of households in remote areas. Thanks to the active performance of the mobile clinics, we managed to attain all the goals and objectives, and within a specific period of time, 29 cases of the coronavirus infection were identified along with HIV/AIDS. At the level of HIV/AIDS patients. Also, some preventive measures and programs were undertaken, and this particular slide presents all these specific actions like syringes dissemination, also some condoms and other actions, and due to the specific measures which were undertaken on time, we managed to prevent and suppress the viral load at the level of the patients HIV/AIDS infected. And actually, in percentage, we had 68 for 2020, for the second 90% presupposed 84, and the third presupposed 86, and that level has been attained by us for the first time. And quite a number of surveys were provided, thus supported by the government of the Russian Federation. And hereby I would like to show some results. Originally, we had to identify the prevalence, the awareness level, the behavioral study, 3,500 migrants were covered by this survey within the period of 1549, also at the level of convicts, and also we had to test the awareness level, and within the same age category, 15-49. And we also had to take the comprehensive analysis and for medical, biological, and social demographic factors, and also being keen on the TB prevalence. Finally, HIV constitutes 0.4. For syphilis, it is 0.2, and for hepatitis, it's 0.8%. And as of 2013 and versus 2020, the dynamics is still the same. And how the condoms are being disseminated, we have a percentage here, and that is 53% for that particular group of the population. We have the prevalence 0. For HIV, 3.1. For syphilis, it's 3.0. And for VGS, it's 9.8. But normally, we detected these cases in some institutions for imprisonment and convicts. And that is the level of condoms application with for the last sexual contact with the not regular partner. And that is what we have for HIV at the level of 1549 over the past 5 years. And the data says that we have 50% statistics, and they're correlated with the data of the routine medical examination within the 5-year period. So how do we oppose HIV AIDS prevalence in the period of pandemics? Of course, we have some challenges to face, but as of today, the most challenging is the insufficiency of the system for providing tests and drugs at the very acute period once we have some complications to occur. For example, COVID-19 pandemics. And in the past, we had quite good reserve for the IRE medications, and they were sufficient for 3 months period, and that's how we combated the prevalence of the disease. And depending on the situation, depending on the transit of tests, depending on the producers of various drugs, we came across the situation that for Tajikistan, it is really hard to get an access to the large batches of those drugs, and minor-sized batches never arrive, only large-sized. And that was really another complication and challenge for us for 2021. And also we have the insufficient development of the coordinative mechanisms for opposing the HIV/AIDS epidemics. What are those recommendations to take into account? To use the acquired experience in the period of pandemics for the addressing of the problems with the involvement and retaining patients for ART. Also, we provide some cross-border projects and programs for opposing the HIV infections prevalence. Also, we have to streamline the efficient exchange of some specific information between the countries for the efficient combating of HIV infection. And also, we have to introduce some pertinent mechanisms for providing services with regard to HIV infection for CIS countries and in the areas of their temporary location. And also we have to retain the patents, the patients upon ATR drugs. And I would like to express my gratitude to those who provided support and aid to us. These are our partners and organizations. They were with us no matter how hard it was in conditions of COVID-19 pandemic prevalence, and altogether we may be more successful in our efforts. Alimjan, thank you so much. Thank you for coming. Thank you for your very interesting presentation. And always it's my honor and privilege to follow your presentation. Let me somehow deviate from the subject matter of our discussion. I've just hired for the Center of AIDS in Tajikistan a young person, and he was so persistent to be a part of this endeavor. And we have another very interesting presentation to come, that is Volova Lyudmila Yurievna for HIV infection and challenges and how to address these challenges.
It was changed. It was modified for help in the COVID-19 patients. Ludmila, the floor is yours. We cannot hear you. Sorry. People, listen to us. Let us express our gratitude on behalf of those who are related to PLWH group in Tajikistan. It is sad that the broadcast was switched off and that it took place till 1 a.m. And now we can just listen to ourselves and we can see ourselves. We cannot hear you. Unfortunately, we cannot hear you. Mila, thank you. Mila, can you hear you? We cannot hear you. Dear technical organizers, let us listen to Mr. Darrow, this case. We will be able to contact him.
Да, снова вас не слышно.
We can't hear you.
1, 2, 3, 1, 2, 3. Yes. It's apparently now working.
Okay.
Should I speak? Or should we wait for Ludmila? So I'm happy also to speak. I think we had a very, very good session with very rich presentation. I hope also you can hear from the chief specialist soon. I think one thing I would like to start with is that medicine is an ever-changing science. That's a lesson learned that we have. We are living in a pandemic situation with 140 million people being infected, and also more than 3 million people, unfortunately, have lost their lives. And also, as you know, we have tools available, which is physical distancing, but also hand hygiene, respiratory hygiene, awareness of the population, and following the public health measures. We also have a health system who needs to cater those severe cases and put them in hospital and take good care of them. And science talks, numbers talks, and very important to find the most efficient treatment. Obviously, there are lots of work ongoing in terms of finding the best antivirals, as you are aware. And we have also, through WHO, done the Solidarity Trial, which is more than 12,000 severe COVID-19 patients who were on treatment, randomly categorized in different categories in more than 500 hospitals, 30 countries. And we find out that many of the antivirals that we were thinking may have effects, they did not show effects on severe cases. Maybe they have other effects, but that's something that needs to still be figured out. The other message that I take is that the health systems and health needs to be prioritized by all population. and particularly important for HIV response, because we know that people who are receiving antiretrovirals and who have a good CD4 count, and these people basically can also have a better response. So very important to continue having infection prevention control and talking to the population, also mental health, as colleagues, previous speakers mentioned, and also adapting the services to the pandemic situation. I think Russian Federation and other countries also have shown experiences how you can adapt the services to the pandemic situation. We don't need every one time per month to go. Maybe you can do 3 months, 4 months delivery of the treatment to serve to people, so there is no interruption and people are not afraid to get their treatment. And last but not least, I think the message that I have is the solidarity, that we need to work together internationally. Cooperation between the countries are crucial, and within countries, among different experts, virologists, epidemiologists, infectious disease specialists, health system, primary care. They need to all of us work together with the governments to make sure that we come out of the pandemic and overcome this situation. With those messages, I would like to thank the organizers for a very good session. I hope we can also hear from the chief specialist at the end. Back to you, Rafael. Over.
Спасибо большое за такие замечания.
Thank you for great comments. Thank you. It is related to both coronavirus infection, but also to combat, it is also related to combating the HIV infection, and we will achieve it. We are committed to making that happen. Sorry, now I should leave you, and we have one presentation. Thank you very much. Thank you. Rafael, thank you. Please stay well and take care. The next event will take place, and now we would like to listen to Ludmila. The experience of this region is vast in terms of helping the patients with HIV and with COVID-19. We're listening to you, Ludmila. Dear colleagues, dear Natalia, I am delighted to participate in this conference online. Let me dwell upon the situation which took place in 2020 in Yamal. There was the AIDS service in Yamal, and we had to focus on the issues associated with the pandemic of the novel coronavirus infection. When the first cases of novel COVID infection were registered, we started arranging our work in Yamal, jointly with the Department of Healthcare, the Department of Rospotrebnadzor. The governor has drafted the resolution about, again, in terms of sanitary and epidemiological activities in order to prevent the propagation of novel coronavirus infection in the district. We also elaborated on issues of staff training aimed at timely identification and prevention of coronavirus infection propagation, and there were also some activities aimed at the patients with respiratory infections. Some of the people were working within the system of oil and gas production at our enterprises, and they arrived from China. We have been observing them for 14 days. We have been monitoring them. And we also started creating our computer software related to coronavirus, and our analytical programs were based on it. A few days later, we faced the ones who have contacted the patients with COVID-19. A train from Moscow arrived here to Novy Urengoy. It included one patient with novel coronavirus cases. This person came back from Kirov, and the ones who contacted them were referred to the place of residence in Novy Urengoy. There were 49 passengers, and novel coronavirus was not identified in any of them, but this contributed to arranging similar events. In real work, the following group of population, which was monitored by us, and we prevented them from COVID-19, was the group of people who just arrived from abroad. In February and in March, many people came back after vacation. First and foremost, they came back from Thailand, the Arabic Emirates, Vietnam, the CIS countries, Dominicana, Congo, to name a few. They came back to Yamal, and medical surveillance was organized for them. They were monitored. The ones who contacted people with coronavirus were paid special attention. We focused on epidemiology of infectious diseases in Yamal. I mean, HIV infection. The rotation expedition method was applied. 1,000 people arrives in Yamal and 1,000 people leave it annually. And our population is a little bit more than 500,000 people. All the enterprises which use rotation expedition methods were involved in these anti-epidemic activities. The governor of our district issued a ruling, number 60, in the course within the framework of which all the employers had to test all the people who have just arrived for coronavirus. The observation was also provided on the basis of the organization, and these rules were fulfilled. All of them were monitored for 14 days, unless the HIV infection was identified, and unless the pathogen was identified in them, they came to oil field and kept working there. And the ones who were diagnosed with COVID-19 were admitted to in-house departments of our medical institutions. We can see the decline of the registration of the cases of novel coronavirus infections in the workers who work in this rotation method. This work was expedient, and it allowed us to reduce the spread of coronavirus infection in Yamal. Still, given all these processes, COVID-19 has penetrated into our district. This has happened over the first months of the pandemic. The workers of rotation method have been diagnosed with COVID-19, and then the disease penetrated into all the groups of population. We did our utmost to admit to all the infected people to hospitals, regardless of any documents. Then, when the statistics increased, and when we considered the severity, we started admitted the patients with severe and moderate cases. The centers were deployed in remote and hard-to-reach regions, which may be there, which might be reached by helicopters, and some of the organizations were also designed for combating coronavirus, including the AIDS Center and some other hospitals. Here on the slide, you can see the changes in the hospitalized people. Mild forms of the disease were observed in the first months. By October and December, the case of severe and extremely severe cases of the disease has increased drastically. It was the substantive load on the healthcare system of Yamal, and it corresponded with the number of patients on mechanical ventilation of lungs. I will not focus on it, dear colleagues. Still, we could see high indicators of morbidity in the workers of the rotation method in both first and second waves of the coronavirus infection. The adults primarily suffered from it. Over 80% were there in the first wave, and approximately 77% in the second wave.
Children and aged people after 65. And the structure of treated in the hospital patients testifies to the fact that we've tried to put everybody in the hospital first and foremost within the first months, and they were dispatched from the fields, and in April and in May we had a very tense situation for oil and gas fields. And we went on improving our statistics. And in addition to the federal register, we elaborated a special program, regional program for combating coronavirus upon the gravity stage. And also we had to identify the status of a patient and results of the medical examination. With regard to the order of the Department of Healthcare, on the basis of our center, for 2 times we had to deploy the hospital. First it was in March and then in October. We did the same thing. And we also had a few weeks of a break, and then we again came across the situation of the new wave when we by 2 times had more cases of COVID than in the previous period. And so we actually retained the conditions for HIV and AIDS infected. We had to somehow reconvert the activity of our hospital, but not a single medical employee had been infected. But that was all due to the situation of prevention. And as to the lab diagnostics, it has been organized on the basis of those labs dealing with HIV infections. And due to this fact, we've managed to had quite a number of those tested, and we were always placed first as to the number of tested, and it enabled us to a large extent to manage and control this infectious disease. And we used some methodological recommendations of the Ministry of Healthcare. And to a large extent, we've been focusing on the patients of the which were just locals mostly, and that was the 17% altogether. And also we had this early diagnostics to implement. And Alexey Viktorovich already told us in more detail as how we administered various services. That was the special recovery aid, and the municipal entities. We had 23 labs and 1.5 million tests were altogether provided, and actually each employee of the Yamal Peninsula was tested at least 3 times. And the local minister for healthcare and the governor were very much focused on this particular effort, as the situation has been changing, and it was discussed at the senior level, at the level of policymakers. And originally we had lack of equipment, lack of PPE, and unprecedentedly in the 17 municipal entities, we managed to install the 3 computer tomography and magnetic resonance tomography. And we started constructing in the new Orengoi and Salihard 2 new hospitals. And altogether, the situation nowadays has been stabilized, and it's going to be our extra value to have this equipment installed. As to the medical staff infected in the overall structure, it was just 6% of them altogether, and they were infected in the medical institutions and within the family. And I should say that medical institutions had only half of this number, just 3%. As to the structure of these infections, which have been acquired on the job, so the infections were registered immediately, and by the tests in the lab, but not so many were registered at the level of hospitals. As to hospitals, COVID-19 was registered at the level of 80%, and only 20 is the share of the hospital staff. And we vaccinated about 10.5%, and 7.2 had been completed, and we also vaccinate HIV deceased. There is 3.4% of deceased. Finally, we got 2.9 as the final statistics. The governor of the Yamal Peninsula visited us, and we got together with the employees. That was a very moral support, and he actually managed to step into the red zone and quite courageously, and he talked with our patients, and he heard the responses right from the horse's mouth, and that was really absolutely indispensable for our team. A couple of comments on the HIV infections. We had actually to get in touch with Lyudmila. We cannot extend our lecture. Sorry, Lyudmila Yurievna, we exceeded our time limit, and we cannot just follow your lecture further. We are still working on testing HIV patients. We have a set of organizational documents for the list of therapeutic measures, and also 95% were examined, and 19.6 were covered by the treatment, and we had the efficiency for 2019, which is about 90%. I'm really grateful to everybody, to AIDS service that within the period of pandemics, we've managed to ensure everybody with the antiviral medication and also complied with the ruling of the federal registers. And also we have quite a storage of antiviral drugs. And we also had the monthly patronage of our patients in-house. And we had mobile teams, and we are very cautious as to the patients with HIV. And it really showed that the mortality rate from AIDS in 2020 has become lower by 2 times versus 2019. And the only provision of our strategy, which was not yet completed, is the coverage for medical examination for HIV. That was 29 versus 34 in 2019. And in 2020, it allowed us to very actively identify at the early stage HIV infections. And we do realize that we may come across the uncontrolled prevalence of HIV. We had some problems with HIV dissidents, but it is another subject matter for discussion. So we really have to terminate our presentation. And really we had to be keen as to the court cases. And that's it. And in conditions of the pandemic, we've managed to arrange surveillance and reporting for HIV and AIDS, and out of 17,000 treated, the all 70% is the share of the okrug, and the rest were just those newcomers. But HIV patients from other regions were not left without our attention. Thank you very much for your kind attention. And I would like to thank my colleagues first and foremost for their stamina, for their courage, for their braveness, and to the government of our okrug and the Department of the Healthcare for moral and material support. Thank you once again, Lyudmila Yurievna, and I'm so thankful to all the attendees to that conference for your patience and for the reporters. We had 7 presentations within an hour and a half. Please come to visit us for the next section, which will be dedicated to migration.
Я хотела поблагодарить за эту сессию и отметить, конечно, так сказать, птенцов из одного гнезда. 5 докладов, да, 5 докладов и уважаемого центрального налоги. Я представилась, я научный сотрудник по мне было все очень интересно, конечно, все мастер. Я говорю о 4 докладчиков, одна эпидемия, вот я хочу эти 4 отметить, которые, конечно, уже широко известны наши сотрудники, которые хорошо публикуются и часто выступают. И всегда дают конференции, читают ваши статьи, изучают документы. Сегодня мне ближе всего касается вам. Почему? Потому что вот это эмоциональное и поэтому методы
Надо было писать. Можно подойти к координаторам, писать завтра нам.
список, если вы завтра хотите прийти
много
Алло, добрый день.
Добрый день. Hello, Khalid. Good to see you.
Hello, Davon. Long time no see.
Yes, good to see you. Good to see you. Hello, Christina. Once more.
Hello to everyone.
Hello, Calix.
Hello, Christina. It's test. We started after 5 minutes. Thank you. Уважаемые коллеги, позвольте открыть параллельную сессию номер 6, которая посвящена чрезвычайно интересной теме миграции. И, в частности, название этой секции «Управление рисками эпидемий в условиях растущей мобильности населения в современном мире». И, конечно, в общем, актуальность этой темы определяется тем, что в последние годы постоянно возрастает объемы миграции, они связаны и с определенными моментами нестабильности в нашем глобальном мире. Количество мигрантов в мире превысило 270 миллионов человек, и вот эти все вопросы мы будем сегодня обсуждать. У нас докладчики из разных стран мира, и позвольте, собственно, открыть эту секцию и представить нашего первого докладчика, представителя Европейского офиса ВОЗ Кристину Мауэр-Стендер, руководителя группы страновой поддержки «Ответные меры на чрезвычайные ситуации». И она сделает доклад на тему отслеживания инфекционных заболеваний у беженцев и мигрантов, региональные перспективы. Пожалуйста, Кристина.
And see me, and you can also see my presentation, which should be coming from here.
Мы пока не видим Кристину. Минутку, Кристина. Пожалуйста, вы видите изображение нам?
Can you see my screen?
Вы видите мой экран?
Пожалуйста. Экран нет, мы не видим экран.
Yes, we can.
From our computers.
Вот, теперь мы видим ваш экран. Да,
Okay.
спасибо.
Now we see your screen.
Thank you very much, and thank you very much for giving me this opportunity to discuss here at this important international conference taking place in Moscow. And as you were saying, Madam Chair, that I will be speaking about how to tackle communicable diseases in the refugee and migrant population from the perspective of WHO European region. And allow me to start with an issue which is close to many of our hearts at the moment globally, and this is the COVID-19 pandemic. So
the question I'm posing to myself is what has been and what is the impact of COVID-19 on international migrants? In 2020, in the last year, we saw very low numbers in arrivals of international migrants because of closures of borders, further restrictions of entrance, and restrictions in general in our countries. And if we compare 2020 to 2016, then we can see that in 2020, only 10% of migrants compared to 2016 arrived to the region. COVID-19 response measures, including lockdowns, border closures, isolation, and quarantine measures, have had a ripple effect on the health of international migrant workers globally. And allow me to indicate some of the economic and social impacts of the COVID-19 related measures in our countries. First, certainly employment status and the income of international labor migrants. The secondly, their legal status. And thirdly, the access to the healthcare services. And all these factors are interrelated to their physical, but also mental health, those of being labor migrants, but also other international migrants, through their access to health services, social determinants of health, such as income, adequate food, shelter, and sanitation. So what are the recommendations for promoting the migrant workers' health during the COVID-19 pandemic, but also in other related or possibly upcoming health emergencies? So first of all, certainly nobody to be left behind, the universal health coverage, ensure equitable access to healthcare and health information to all migrants. But also we know that some migrants and some migrant workers may live in a labor accommodations or crowded housing in our region. And therefore it's important to ensure that employers are adhering to the WHO guidelines for isolation measures which do not violate human rights. We also do know that many undocumented migrants avoid seeking medical attention for fear of registration leading to detention or possibly deportation. And therefore it's important to ensure the confidentiality of the data and in order to avoid the further marginalization and stigmatization of migrant communities in general. And we also know that stigma can increase the isolation of these groups and impede people from reporting symptoms, seeking medical advice, or testing themselves, which is harmful to both the migrant health, but also to the general population. We also know from all the populations, but also the vulnerable groups, that health promotion messaging and also the risk communication in the context of COVID-19 is crucial. Therefore, we think that it's important to develop the public health communication and risk communication targeting these vulnerable populations like labor migrants, to ensure that there is awareness about what's happening, what help can be sought, but also building the trust and empowering those communities to seek for their advice or help. Last but not least, the health professionals and the health professionals working at the front lines of COVID-19, it is important to empower them and raise even further the capacity to understanding the health-seeking behaviors and access to and use of healthcare services by migrants, by migrant communities, as it is important and crucial for COVID-19 situation, and particularly the case reporting. Some real life examples I wanted to share with you. I'm sure there's many more out there in the European region, but how the countries have taken action to ensure that international migrants and labor migrants are included in their national policies. Allow me to give an example of Ireland. Ireland, who introduced in March 2020 a COVID-19 pandemic unemployment payment but provides financial support to all those people in age group of 18 and 66 who lost their jobs and their income because of the pandemic related to COVID-19. And this policy in Ireland is also including regular as well as irregular migrant workers. So this is Ireland. The other example I wanted to bring to your attention is the more related to the labor migrants and labor migrants, many of them working in the Russian Federation, and particularly the action that Uzbekistan and Kyrgyzstan have taken together a number of partners, to set up a council for assistance to migrants who are labor migrants in the Russian Federation, to make sure that they get the counseling and psychological assistance, possibly also medicines and food if needed in case of isolation during the COVID-19 pandemic. So those are just two examples of many, which we can also discuss later during this panel. Now I come to a topic which is very much at the heart of our discussions and our minds in Europe, but also globally, COVID-19 vaccines and how to ensure that we do ensure the equitable access of vulnerable populations, including international migrants and labor migrants. I think we all agree that it is a tall order to provide a clear direction to ensure equitable access of vulnerable population. But I'm happy to say that some progress has been made. Particularly, WHO's Strategic Advisory Group of experts suggests a tiered system to prioritize who should receive the vaccines. And this expert group advises that low-income migrant workers, as well as irregular migrants, should be defined as a priority group to be allocated the COVID-19 vaccines globally. So they are defined as a priority group to receive the COVID-19 vaccinations if they so wish. Of course, operationalization of that advice and this recommendation is crucial. We do know that there are 92 low and middle income countries globally which are eligible to get the access to COVID-19 vaccines through the Gavi COVAX system. And 51 countries so far, among those 92, have received the vaccines, at least the first shipment of COVID-19 vaccines. Those countries who are part of the COVAX global system have a requirement to have national vaccines deployment plans. And as of March 2021, if we looked at those plans, those national plans, and analyzed those, we know that some of them do include refugees and migrants into their national vaccines deployment plans, but many also don't. And therefore, WHO, in close cooperation with UNHCR, IOM, and UNICEF, is discussing currently at the global level how to advocate and support countries to include international migrants to their national vaccines plans. And even if they have included them, to make sure that we know all those people, those vulnerable population groups in those countries really having the access to vaccines. Making great conditions to vaccines uptakes among those vulnerable population is also absolutely crucial, because we know that particularly irregular migrants are afraid to come forward and talk to the authorities and seek for help or receive the vaccines. But also, I think there is a role for the public communication, risk communication, and also role for media to make sure that awareness is there and those people who want to access to the vaccines are able to do that. So this was about the COVID-19, the situation we're living in. I also wanted to briefly touch upon the HIV, and again from the perspective of the WHO European region, and tie this into the international migrants context. You see the chart on that slide on your left side, and this is showing the percentage of cases of foreign origin among total numbers of diagnosed HIV in member states of the European region of WHO. And we know that there is a growing evidence that a significant proportion of refugees and migrants, including those originating from countries with high levels of HIV prevalence, acquire infection after they arrive to the WHO European region. However, we should be mindful of the fact that the region is large, of 53 countries, and there are also large regional differences. For example, if we look at the European Union countries, then 40% of diagnosed cases are migrants, both sub-regional, 40% of diagnosed HIV cases are the migrants. And therefore, we have to be mindful of the fact that we need a sub-regional approach to tackle those sub-regional specificities and differences. We also know that migration can create additional vulnerable situations where infections can occur and spread, and such an exposure to sexual violence, substance abuse, or secondary risk-taking behaviors linked to the poverty or isolation or the marginalization. So therefore, we need to act in a coordinated manner, but at the same time, taking into consideration the regional and sub-regional specificities. Now coming to the TB, tuberculosis, and again, from the perspective of WHO regional, European regional angle. Some data first to set the scene. An estimated 275,000 new and relapsed TB cases occurred in the WHO European region and its countries back in 2017. And this is equivalent to an average incidence of 30 cases per 100,000 population. And this represents, from a global perspective, around 2.8% of the total burden of TB in the world. There is also substantial disparity in the burden of TB among WHO European region member states. And we know that around 85% of all incidents in TB occur in 18 high priority countries out of 53 in the WHO European region. We also know that foreign-born individuals make up about 8% of all TB notifications in the region, but the proportion varies quite substantially geographically. Migrants in Europe experience a disproportionate burden of MDR TB compared to non-migrant populations, but little so far is known about the burden of MDR TB in specific migrant groups, including refugees. And we also know that there are twice as many males as females reported among all incidents of TB cases in the region. And now a few words about the migration and TB to add to my previous slides. Migrants may have high risks of becoming infected or developing TB depending on their incidence of TB in the country of origin, but also the conditions in which they travel, and of course also the living and working conditions in a country of immigration, their access to health services and to the social protection. TB is very rarely transmitted from migrant population to the resident population due to its low infectiousness and the limited social mixing of two populations. And I'm happy to say that WHO European region is the only region in the world with consensus documents on the minimal package of cross-border TB control and care interventions. And this basically means that the package ensures the access of medical services, irrespective of the migrant's registration status and non-deportation policy until intensive TB treatment has been completed. And last but not least, as I'm working for the WHO Region Office for Europe, and one of my responsibilities is also the Migration and Health Program. So what do we do and how we can help countries? I think there are three key words which I'm happy to elaborate on later on. One is that we're producing the knowledge and evidence on migration and health to support countries to make better policies and inclusive policies. We are also supporting countries on bilateral basis to make sure that those policies are based on international recommendations, international regulations, but also how to best implement those policies and how we can learn from each other and make sure that there is a solidarity in terms of lessons learned. And then last, we're also working quite a bit on general information and advocacy area related to migration and health within the WHO, but also certainly towards our member states, the 53 countries in the WHO European region. And I would like to thank you and thank you for your attention, and happy to take any questions at a later stage of this panel. Thank you.
Большое спасибо, Кристина.
Thank you, Christina. Let me ask you one question. Let me clarify which proportion of HIV-positive migrants has already come to the countries of the European regions with HIV. You have already dwelled upon it, and I couldn't understand these indicators.
Okay, so maybe what I can do is I can share my presentation again, just to put up the slide which was related.
Просто достаточно, если вы...
It's enough to tell us the proportion. How many of them? 40% or 20%? I couldn't understand it accurately.
So what I was saying, and sorry not to be clear enough, is that what I was saying, that I think the European region is large. It's 53 countries, and we have a big disparities there. In terms of the European Union, which was one of the examples I gave, the European Union countries, 27 countries, if we look into those countries in as a group, we know that 40% of HIV diagnosed cases are coming from migrants. So 40%, which is very, very high in that particular sub-region of the WHO European region. I hope I did answer to the question.
Да, спасибо.
Yes, thank you very much, Christina. Maybe some other questions will also be related to you. You are ready to ask your questions, and at the end of the session, we'll try to answer these questions. And now let me give the floor to another speaker, our esteemed Davron Muhammadiev, the coordinator on healthcare in the European region, the International Federation of the Red Cross Society and Red Crescent Society. I am happy to see you, Davron, here at the conference, and now we give you the floor. And the topic of your presentation is health and legal barriers on access of different categories of displaced people to health services in the Europe region. Thank you very much, dear organizers of the conference. Natalia, thank you very much. I am delighted to see you. Fortunately, we will also see one another in person. Let me represent our recently conducted survey findings and the key issues on medical and legal aspects of the barriers to access of different categories of displaced people in the European region. First and foremost, let me provide an overview of the migration situation and provide the key data of the situation and the corresponding summary based on this study. The last massive displacement of the population to the territory of the European region was initiated in 2015-2016. Over the past 5-6 years, we have formed this flow of migrants. It is related to transportation of the population from the Middle East region via some channels, via Turkey, Greece, Italy, and Spain, and also the Russian Federation to the Western countries. Let me say that the trend of migrational situation is not represented in the CIS countries, but I reported on it at the last conference. I will just refer to these studies. Let me start from the fact that according to the mandates and the activity of the Red Cross and Red Crescent in the domain of migrant health, we pay special attention to responding to emergency vital needs of the migrants and the needs of health, and we provide necessary medical aid in the access of basic services, in sanitary and education of migrants, and also first aid and psychosocial support. Also, our mission is promotion and protection of migrant interests. We provide them with access to healthcare services, dwelling upon eradication of any forms of stigmatization and discrimination of migrants. The findings of this study are represented. It was conducted by the Institution of Development of Management of Healthcare, and which is cooperating with the WHO Center on the Health of Migrants. We can see large scientific institutions which are dwelling upon the health of migrants. It was conducted in close cooperation with the Society of the Red Cross, Bosnia and Herzegovina, Northern Macedonia, Montenegro, Serbia, and it was supported by our partners and the Red Cross. The key goals of this study included receiving scientifically substantiated data on the access of migrants to medical services and the chance of using them, the level of medical literacy of the migrants compared to in the system of healthcare in the country where they're located. We are also going to define the key challenges related to healthcare and to get the data on specific needs of different groups of population, such as women, people with disabilities, and elderly migrants. The methodology of this study was the following. Our methodological basis was presented by scientific institutions of the Red Cross. We conducted surveys aimed at both migrants and the employees of the organizations working with migrants in each country. We've interviewed 150 migrants and 120 employees of various governmental organizations and international agencies, such as the Red Cross, the International Organization on Migration, and the Great Commissioner on the Refugees in the UN. The study period lasted from March till July 2020. It was long-term. We can see the topicality related to the vulnerability of migrants and the vulnerability related to the 2020 COVID pandemic. We will also develop on these issues. We have analyzed 20 indicators on various aspects such as health condition of migrants, prevention of communicable diseases, traumas, mental diseases, immunization and vaccination, which is of prime importance nowadays, and also access to the public healthcare system. It is impossible to cover all the results of this study, but you can see the links here and you can familiarize yourselves with these details of the presentation. As for demographic indicators, the average age of migrants, and most of them were examined. They were aged 18, 20, 19. They are rather active, and some of them were aged 30, 39. Most of them were men. They were not married. They didn't have children, apart from a few of them, and most of them were Muslims, but only a few of them were Christians and representatives of other religions. There were also representatives of Africa, Asia, Middle East, Central America. As for the self-esteem of the health condition of migrants, we highlight that most of them felt either extremely good, in 39% cases, or good in 12%. Most of them believe that their health condition is satisfactory. As for chronic diseases, most of them marked arterial hypertension, rhinitis, eczema, dermatitis. Mental diseases and disorders were of prime importance for migrants. Chronic anxiety, chronic depression. This aspect was of paramount importance. Also, let me highlight the regularity of medical examinations. Most of the surveyed people underlined that they had undergone the medical examination right after arrival in 48 hours or over the first week upon arrival, and a few of them mentioned that they had undergone the medical examination more than 3 weeks later after the arrival. As for the organizations which conducted medical examination on arrival to in the country, you can see the differences in different countries. In the lower slide, most of them noted that the representatives of non-governmental organizations were provided by medical examination. 56% of people. In Montenegro, 90% of migrants underwent medical examinations conducted by local healthcare organizations. In such countries as Macedonia, Serbia, and Bosnia and Herzegovina, we can see the representatives of international agencies. And another important issue is awareness of migrants of communicable diseases which are prevailing in Europe. Almost all of them answered that they were aware of communicable diseases. More than 33% of people noted it. 53% were not aware of it, and 25% were partly aware. You are able to see this chart. I will not elaborate on the details. Now let me move on to the awareness of key symptoms of communicable diseases. A very good and fair knowledge of key symptoms was demonstrated by 50% of the respondents, and a little bit fewer people showed lack in knowledge in terms of awareness of key symptoms of infectious diseases. Here are the measures on prevention of communicable diseases. Over 46% of interviewed migrants said that they were aware of prevention of infectious diseases. In the course of the study, which is rather satisfactory for us, the profile of awareness and education of migrants is improving. A few years ago, we conducted a study in the Russian Federation. This percentage was a little bit lower. According to Russian studies and our current experience, the awareness of the migrants on prevention of infectious diseases is also improving. As for the examined migrants, few of them were women. Some of them were women and others were men. And women were asked about the accessibility of preterm care, antenatal care, because most of them were either pregnant or on this stage, and only 2 of them said that they had access to antenatal care, and 4 of them said that they did not have any access to antenatal care, which is an insufficient factor. This slide demonstrates the information received from the representatives of international organizations. It was assessed on provision medical assistance to migrants. you see that in 41% of cases, medical aid was provided by the representatives of international agencies or humanitarian organizations. In 37% of cases, it was the government which provided this assistance, and in 23% of cases, it was provided by intergovernmental organizations. This aspect is related to provision of medical assistance, and the lower slide shows the activity of migrants while benefiting from these services. The migrants from Afghanistan were the most active ones because they took advantage of the services available. Some other migrants descended from either Pakistan or Morocco, and Syrian, Algerian, and Iran migrants were not that active. They did not refer to medical institutions. That's actually only when they received the suggestion of the representatives of medical entities, they could refer to the medical institutions. As for awareness of migrants in immunization, this issue was included in the list of before the pandemic. The awareness of migrants on national immunization protocol for the host population is rather high. Vast majority of the migrants, 40 to 52%, were fully aware of immunization issues. And this slide also shows on the right side that most of them, 50 to 69%, highlighted the importance of these events according to the immunization calendar, and they were also ready to be vaccinated. They know that the vaccine is very effective and an economically viable tool on overcoming the infection. It has already been mentioned in the previous presentation of my colleague from the WHO. It is important to include migrants in such events. It is of prime importance from the psychological point of view and from the point of view of perception of the need of immunization and vaccination. Which barriers exist and which of them was identified? I mean, psychological barriers and some other barriers, and some of them are common in other countries. There's a linguistic barrier which is of prime importance. While receiving access to medical services and medical knowledge of migrants, in this case, 33% of migrants spoke only one foreign language, and 35% of migrants did not speak any language apart from their mother tongue. In 21% of cases, migrants could speak more than 2 foreign languages, or 11% of migrants spoke 3 or more foreign languages. Our Society of the Red Cross attracts such migrants in order to provide communication with migration communities. They are volunteers on dissemination of knowledge and education of migrants. Another key aspect of the barriers was the amendments in the legislation and the policy in 2015. More than 35% of migrants said that in these 4 countries compared to 2015, the policy and the legal approach to migrants were improved. Some of the migrants use almost the same services of healthcare as the local population does in terms of COVID-19 vaccination. We can see the recent data. Some of the countries included the migrants in their vaccination plans, which is really great. Let me also outline migration and COVID-19. Christina has already dwelled upon it. Still, from our point of view, migrants, including other categories of displaced people, such as the ones who are asylum seekers, were affected by the pandemic in terms of healthcare and the social and economic factors. The migrants who are on the way to the study and the ones who are placed here need either international protection or legal status. They are especially vulnerable. Due to the governmental measures implemented in the course of COVID-19 in terms of limitation on displacement, they negatively affect the health of migrants. Invariably, their anxious condition and their health problems is caused by lacking access to healthcare services, and they do not also have any access to food and other resources which exacerbate their health condition, and the legal limitations also exclude them out of national plans of vaccination, which worsens the health of foreign people. You can see that our attitude to foreigners is changing during the pandemic, and the negativization of this approach is of prime importance in terms of general atmosphere and access to healthcare services. As for the key summary and recommendations, let me highlight that our migrants have a limited access to the services of healthcare, and this situation was exacerbated by the pandemic. The migrants are not fully aware of their health condition and the preventive measures in terms of communicable and non-communicable chronic diseases, although this situation is changing for good. Linguistic barriers may be considered as the most significant ones in the access to healthcare. Sanitary enlightenment and outreach of healthy lifestyle is crucial to migrants and refugees. Unfortunately, let me highlight that no short-term and mid-term and long-term decisions of improving the health of migrants take place. I mean, the Red Cross and some other agencies which are now supporting the vital needs of the most vulnerable migrants. Another important issue is the fact that this scientific research allows us to renew the dialogue with the stakeholders, with the public entities in terms of decision-making on long-term tools and amendments to the legislation in terms of access to healthcare services. In terms of migrants, here you can see the quotations of the migrants. They said that when they were interviewed, there are some preferences on the information in the mother tongue. You can see the quotation that the police didn't allow them to stay with their children in the camps. The Iraqi women from Northern Macedonia said, some Iraqi migrants said that they wanted to get better humanitarian assistance of the government, and also the presence of interpreters was crucial in medical assistance, and the migrant of Morocco required more information and more points on medical assistance. They reiterate the importance of this medical aid. I have already highlighted that the organizations of the Red Cross and the Red Crescent do their utmost. Let me highlight that some interesting studies and initiatives are undertaken by us in the Balkanic countries and some other parts of the European region. You can see curious models in Denmark, when the Danish Red Cross has organized 2 clinics when the medical aid is provided to migrants voluntarily. The RF is another interesting example of providing treatment of HIV displaced people in Ukraine, and there are also some initiatives on economic estimations of accessibility of the system and the services of healthcare. The RF has also conducted some interesting activities. Economic estimations on deportation and public spending related to health condition exceed the expenditure which could emerge if this public government had sent to the healthcare of migrants. These topics are interrelated despite various geographical contexts of our studies. They testify to the fact that we need long-term solutions and the participation of the government in terms of medical aid to different kinds of migrants. Thank you for your attention. Let me finish my presentation. If you have some questions, don't hesitate to ask them.
Thank you, Davron, for your wonderful presentation. You indeed represent the organization which spares no effort as to contributing to the health of migrants and taking care of them. And you are very emotionally involved, as well as the brilliant expert. And I do hope that at the end of the section, we're supposed to have some questions to come. Please do not exceed your time limit for the presentation. We have another 3 speakers to come. And the next speaker represents the organization of the Red Cross and the Red Crescent, and he is the General Secretary of Syria, Irkusi Khaled, and he is going to present a very interesting presentation on the involvement of the population and the public healthcare system from Syria. And he was involved in some certain situations due to the military conflict, and he was dealing with quite a number of displaced people and migrants and all the problems pertaining. Thank you so much.
Thank you. Good day to you from Damascus. Of course, as you know, the Syria crisis has been here for 10 years, and the Syrian Red Crescent is the lead humanitarian agency in responding to this crisis. It is known globally the correlation between migration, displacement of population, and public health, and considering the importance of containing the risks of global emerging diseases. The fact that it poses significant source of concern that has raised the attention of infectious diseases and emerging new ones. Here we should mention the great efforts that has been made worldwide to combat many infectious diseases such as malaria, AIDS, plague, Ebola, cholera, and others. The process of migration and population movement constitute a major challenge for global public health. It is one of the factors that cause the spread of infectious diseases between countries and societies. And from here, it becomes clear the need for cooperation and development of multi-level, multi-party policies to overcome those challenges. The migrants may suffer from diseases or symptoms different from those suffered from by resident population. Likewise, conflicts and crises have pushed a large number of people to internal and external migration. As a result of this, the transmission of many infectious diseases, as well as the emergence of mutations of those diseases that might be more deadly, have longer duration and worse impact on the society. It is worth mentioning some of the practices that helped us, of course, also reduce and prevent the transmission of diseases as a result of migration and population movement, internal population movement. Examination of migrants or internally displaced persons at border points and places of gathering and documenting those results. triage of infected cases and determining their severity, providing necessary medical services, including referral to hospitals, apply isolation and quarantine as needed. The Syrian Arab Red Crescent, SARC, has participated in many humanitarian responses during the past 10 years of the Syria crisis, evacuating people from hard-to-reach areas to shelter centers, where various services have been provided, including medical services. We mentioned, for example, the response of Eastern Ghouta near Damascus that happened 2 years ago, where the number of people exiting from Eastern Ghouta to shelters was around 150,000 people who exited during 1 week. And the response our response to this was through provisioning of many services. For example, preparing shelters to receive displaced, where accommodation rooms and communal kitchens were equipped, preparing the Watson network, water and sanitation network, securing bathing and drinking water, implementing health promotion activities, including implementing insect and rodent control activities, with the aim of limiting the transmission of and outbreaks of epidemics. Provide food and food parcels and ready-to-eat food parcels in order to enhance immunity and maintain health. Secure medical services of primary health care, such as minor surgeries, psychological support, mental health, physical therapy and mobility aids, and nutrition support through the establishment of 3 medical health clinics and assigning 10 mobile clinics daily, with 25 ambulances and their trained teams, the recruitment of medical personnel such as doctors, pharmacists, and nurses to work on daily basis, as well as volunteers to provide psychological support and community health during the period of more than 2 months, where those people remained in those shelters, and after those 2 months they moved back to Eastern Ghouta when the conflict in that area was over. Through the documentation of disease cases, many non-communicable diseases have been observed, such as chronic heart diseases, stress, diabetes, cancer, and others, as well as infectious communicable diseases such as diarrhea, hepatitis, and blood-borne diseases and AIDS, in addition to fractures, wounds, and burns. All cases have been dealt with, and the ones that require treatment have been referred to hospitals, resulting the number of medical services provided reached 415,000 services in those 2 months. Likewise, the response in homes, also the same situation. Medical services were provided for 10 days, 36,000 medical services. The response in Daraa in the south of Syria, also for 40 days of population movement, 16,000 services. And finally, in Aleppo, there was also medical services provided during the months of population movement, which reached 51,000 services. In its multi-sector emergency response, the Syrian Arab Red Crescent have attached great importance to health sector, especially services provided to the displaced population, with the aim of limiting the spread of diseases among the displaced, as well as preventing the spread of those diseases in host communities and reducing mortality rates. Syrian Arab Red Crescent plays an important role in helping the health authorities in the country to strengthen and improve the health and public health sector all over Syria through securing diversified medical services to reduce infectious and non-infectious diseases, disability rates, and support mental health, as well as participating in the surveillance of emerging and renewable health threats. Today, the whole world suffers from health, social, and economical impact of COVID-19 pandemic, and Syria is one of those affected countries. As the epidemic has greatly contributed to the increase in the burdens already resulting from 10 years of crisis in Syria, and many restrictive measures and sanctions imposed on Syria that is affecting our humanitarian work in many aspects. Since the start of COVID-19 epidemic in Syria, the Syrian Arab Red Crescent sought to take necessary measures and carry out activities that contribute to preventing the spread of the epidemic and mitigating its effects at various levels. So support is needed in terms of vaccines and for the health system in general, so we can overcome the challenges and provide health to the people in need all over Syria. Thank you.
Большое спасибо.
Thank you so much. It's a very appealing experience of yours, and the scale of this aid provided is very, very surprising. And thank you for your contribution. We do realize that it is really a really painstaking issue. It's really hard for all the migrants. And once in 3 months, migrants may come to one country, then get back to their motherland. It's a principally different configuration of our sort of migration as opposed to the Syrian situation. And indeed, you have a very serious problems with migration. Thank you so much. I hope our audience will put some questions later at the very end of our section's deliberation. And now I would like to give the floor to Natalia Saposhnikova. She is the head of the clinics of the diagnostic laboratory of the Moscow R&D Center for Dermatology and Cosmetology. And she's going to talk about the expertise and findings of this particular entity. Natalia Alexandrovna.
Good afternoon, dear colleagues. Let me express my gratitude to the organizers for the invitation to this conference. We have been participating in similar conferences exclusively online. It is the first in-person conference for me. It is a true pleasure because we can see the prospects for the future. The topic of my presentation is the experience of examining labor migrants for HIV and syphilis in Moscow. Labor migration is a typical process for many world countries. The labor flow of migrants constitute the labor reserves for industrial enterprises of many countries, for transport, for different services, for construction. Russia is not an exception to this rule. On an annual basis, over 10 million migrants cross the borders of the RF. The particularity of the labor flow is the following. The migrants arrive in Russia from unfavorable regions from the ideological point of view. I mean, the previous republics of the Soviet Union. Thus, the federal law was enacted in 2002, number 115, about the legal status of foreigners in the RF. This law stipulates the goals and the order of providing the documents for temporary residence, patents, and the permits to working in the RF. When the migrants are examined for different communicable diseases, which are hazardous for others, which may be the reason for giving the temporary permits for living in these regions. And if the results are good, if the test values are positives, they are allowed to work in the RF. According to the results of HIV examination, the migrants receive the certificates on absence of HIV, and then they go to psychiatrists and to a narcologist. Here you can see the number of granted documents and the structure and the dynamics, which was initiated in 2012, and it was finished in 2019. Until 2015, the migrants were examined by commercial medical institutions, and only in 2015 a new building was erected. Its useful area is over 50,000 square meters. 7,500 people may be here during the shift, and it is divided into convenient areas, and it spans the area of one window, 185 windows where they're serviced for 10 minutes. The documents are received from the migrants, and then they apply for patents and for notary translation force. And then the medical insurance is provided to them. There is also a bank zone where 70 operational terminals of service are provided, and they're serviced for 8 minutes. A dactyloscopy zone includes 92 workplaces, and they are serviced for 5 minutes. They are checked in the database. A dactyloscopy of 10 fingers, of palms, and also the photo of them is provided. And there is also a testing zone encompassing 445 workplaces. The exam on the knowledge of the history of Russia and the Russian language and the legislation of the RF is conducted there. The medical area is part of our branch. It is the multi-purpose Medical Center of Labor Migration. This branch is part of the Center of Dermatovenerology and Cosmetology. It is represented by 175 cabinets, and the time for examination is up to 30 minutes. If all the stages have been overcome, the migrants receive patents and permission to work. Our medical center is including these spacious halls, which allows us to follow social distancing during the pandemic, and the migrants are serviced in a high-quality fashion. The branch of the Multifunctional Medical Center of Labor Migration carries out medical examination for infections which are hazardous for others, such as syphilis, HIV, tuberculosis, and they're also tested for drugs. It is the only organization in Moscow. It is allowed to carry out medical examination of foreign people in order to grant patents for work. You can see these premises on the slide. Over 12,000 square meters is occupied by this center. It includes 175 of cabinets, including the collection of biomaterials for drugs, such as urine, and there's also an express laboratory in this area. There are 33 cabinets of dermatovenerology, fluorography cabinets. There are 31 of them. Migrants are examined by 50 physiatrists, 35 narcologists, and there are also 18 cabinets of blood test collections. Since May 2016, the center has organized its own laboratory, which enables it to decrease the time of the examination up to 24 hours. Which diseases are hazardous for others, and which diseases are tested. They are tuberculosis, syphilis, HIV infection, lepra, and COVID-19 since 2020. Screening tests for HIV and syphilis for migrants are carried out by the immune fermented method in IFA analyzers produced by Tican Austria. The tests for syphilis and HIV infection are conducted by immune blotting method, and special experts are involved. This slide shows the algorithm of medical examination, which was devised in 2020. The migrants spend only 1 minute at the reception, then they are tested for drugs in urine. It takes 2 to 3 minutes. Then they are going to a dermatovenerologist or a dermatologist. They are referred to fluorography if there is a suspected case of some changes in lungs. A physiater and a rentgenologist and a radiologist communicate with the migrants, and they decide whether the migrants need a smear for these diseases and the microbacteria of tuberculosis are needed or not. A psychiatrist and the narcologist are also examining the migrants. Till 2020, we didn't take a smear for COVID-19. Now we take it, and the blood collection takes approximately 5 minutes for HIV infection and for syphilis. If it is required, there is also a smear of the nose for lepra if it is suspected. The medical part of this center also includes some treatment rooms which are dedicated to vaccination, the vaccination from measles and seasonal influenza. Infection doctor also communicates with migrants, and this time from the reception to test collection takes 40-45 minutes in total. This slide shows the algorithm of this study for syphilis. Syphilis screening is carried out by IFA tests. Total antibodies are determined. MG antibodies are also identified if needed. When they receive positive results in the laboratory of the center, immune blot is conducted, and it is possible in severe cases. There are also some cases of late syphilis and history of syphilis. Thus, we use the tests of pale trypanemia and fluorescence reactions. They are conducted in our laboratories free of charge. It is the responsibility of the center. When patients are diagnosed with syphilis, they are receiving treatment, but they may refuse to get treatment. Otherwise, they will undergo deportation. But if they agree, we examine them once again, and the migrants may, with the patients with the syphilis history, can receive a permission to work and a patent. The algorithm of study for HIV infection is different. Screening includes immune enzyme analysis, the repeated study, and the confirming tests in immune blotting. If a positive test for HIV is confirmed, the patient undergoes a deportation out of the RF, and it is also typical of tuberculosis cases. The CT is conducted as well as PCR. If the results are positive and the diagnosis is in the migrants, they are deported. The Center of Dermatovenerology and Cosmetology is the only organization in Moscow to be entitled to carry out medical examination of citizens in order to issue the patents and the permission to work. Only 7% of these migrants are examined in the private system of healthcare. It is not that good, but everyone has the right to make choice. After the transition of the examinations of foreigners to the public sector of healthcare, we witness a significant increase in identification of infectious diseases. 2.5 more cases of syphilis were identified. In 2018, we observed the full-scale flow of migrants. 1,634 cases of syphilis were diagnosed in foreigners, which is 0.33% of the ones who were examined in the migrational center, and 51% in the general structure of syphilis registered in Moscow. These patterns of tuberculosis were the following. In 2018, 462 cases of tuberculosis were diagnosed in foreigners, which is 0.08% of the examined, and 14.03% in the structure of tuberculosis registered in Moscow. There were 422 cases of HIV infection cases. I dwell upon 2018 in order to understand what is happening right now. We can see the medical examination of foreigners over the last 3 years. The number of migrant flows were limited in the end of 2019, and the flow of migrants was a little bit lower. 497,000 migrants were examined in 2019. 1,164 cases of syphilis were diagnosed. There were also 478 cases of syphilis and 332 cases of HIV infection. And we also started examining the migrants, testing the migrants for COVID-19. These numbers are hefty. In 53,495 migrants, 1,451 migrants were diagnosed with COVID-19, and 181 migrants were HIV infected. The flow was limited. At the end of the year, they extended, and the borders were opened on the 1st of April. Still, the morbidity is rather high. HIV infections and syphilis are part of history of many patients. There's a 1.2 ratio. When we see the history of syphilis, we can see 23,000 people. And on the 19th of April, we could see large COVID figures, whereas the morbidity of HIV and AIDS was insignificant, and as well as tuberculosis. To sum up, let me highlight that the effective modern organizational model of medical examination of labor migrants was implemented in Moscow. And the creation of this branch of the Multifunctional Medical Center of Labor Migration on the basis of the medical institution of the public property form allowed us to significantly reinforce the governmental control over diagnosis of syphilis, HIV infection, and tuberculosis in Moscow. Thank you very much for your attention. Thank you for having me.
Thank you. Thank you, Natalia Alexandrovna. I'm very impressed with your space and nice-looking premises. I have some personal questions to you. What is the procedure in identification of COVID-19 at the level of migrants? We do realize that HIV presupposes deportation, and we know that procedure. And some treatment may be provided. But as to TB and COVID, the question arises, what is the epidemiological threat we are posing. The TB and HIV are chronic diseases, and as to the load onto the Moscow-based hospitals, it's hard for us to do. But as to COVID-19, infectionists are fully in charge of that. And they have the same algorithm as for the locals and same to migrants. They offer, hospitalization, first aid, ambulance, and the migrants have an access to all these services. All those coming to the city, and actually all of them are eligible for the medical aid for the emergency, and it is provided on a full-fledged basis. It is on a free of charge basis. The way it is provided, but some services could be payable, but hospitalization plus treatment is all done on a free of charge basis as the emergency aid measures. So the numbers are high, and all these people were provided with a highly qualified assistance with a very good result. I haven't heard anything as to the mortality, and everything looks more or less okay. And my last question, what is the cost of this full package of services? Within 24 hours, the migrant may be given the results of his medical examination. And the load on diagnostics for COVID-19 has been taken by us, and the migrants never paid any copy. I mean, I am talking about the full package. It's 10,000 rubles as the full medical examination. They get a patent. No, this is the this is our own money. It is 10,000 rubles less COVID, and this is the burden we've assumed on our shoulders, and this is a part of the free of charge service if the regular procedure is rendered. And we may somehow, without any trading or bargaining, assume this responsibility. Nobody knows what will be going on in the future, as our budget is somewhat meager. Probably the situation will change, but this is how it goes nowadays. Thank you for your very interesting presentation. Maybe some other questions will come. It's 50 plus 50. I've never seen anything of that sort in the past. And our last speaker is Irina Gennadievna Kostetskaya. She represents the organization which she was involved in the organization of our event, and they are working very effectively in the East European countries. And she's going to talk about the mobile clinics and providing medical services. She represents Full Speed Info Svязь, the deputy director. Dear colleagues, my mission today is to talk about our Russian program for technical aid, for technical assistance in aid and other infectious diseases, and also rendering the assistance to migrants when they have to get back to their families. And also we provide the same assistance to their families as well. And our key objective was to enhance the capabilities for testing the infections of HIV, AIDS, and syphilis for people who live far away from the medical institutions where those tests could be taken. And when we planned our project activities, we had two ways. first and foremost to organize the mobile teams for testing. We had to be fully dedicated, justified, and we've attained our key goal and the integration of services on the free of charge basis for testing HIV, syphilis, hepatitis, and other diseases, and every person is to be given a chance to be subject to such testing, those prone to higher risks of those diseases. And these mobile clinics haven't been yet seen by the majority of our audience. And this is how it looks like, those mobile clinics. We have 3 sections. One is a lab. We use express tests, and 2 more rooms are attractors. They attract the attention of people to us. This is the functional diagnostics room, and people are provided ultrasound diagnostics. Also, they may visit the general practice therapists, and hygienic services to be provided. 70% is the share of women. When such mobile clinic comes to some rural areas, men are normally are in migration, and their family is at home. And gynecological room attracts the attention of many women, and the majority of them visit this particular room. Originally, they do not even think about any kind of tests, and thus they are involved into our testing program. And in addition, the result we've acquired as of the mobile clinics is the assistance to the primary link in the healthcare chain. And in the majority of the countries, primary aid is provided. This medical prevention examination. We have more mobile clinics in Kyrgyzstan, but it couldn't be 100% covered, as within a year period, we are not able to visit all the residential areas and cover the local population. But year over year, the number of mobile clinics is growing. As to Tajikistan, and we want to show you the scale of our efforts, more than 240,000 patients were covered, and 87,000 were tested for HIV. And what do we mean by that? The tests for other infections look more or less the same, but originally we offer the test for 4 types of infections, and people may come specifically to be tested for hepatitis, as it is a very popular disease, and whole families come with intention to be tested this way. As to Armenia, more than 38,000 people were covered by these services, and 47,000 were HIV tested. And Armenia is focused on the testing of the maximum number of people, in addition to providing other services, medical services. But the availability of the mobile clinic and additional services make it very attractive for the labor migrants. And in addition, we had more than 700 tests provided for coronavirus antibodies, and we resort to this test nowadays. well, and I'm going to develop on it later in more detail. And the medical teams are to be tested, as well as the patients having high temperature, fever, and other complaints, and they are tested just separately in a special room for paramedics or in the local administration, having the mobile clinic nearby, so that these people could not be invited onto this mobile clinic. And as to Kyrgyzstan, more than 257,000 are covered. 78 plus thousand were tested for HIV, and as to COVID antibodies test, it encompasses 3,500. And the clinics, the clinic of ours was placed at the border of one of the regions of Kyrgyzstan. We provided PCR tests, and those coming into the this region were subject to such tests. But it turned to be a very costly one, costly for the budget, as we found out later. And these are some general statistics as to how many people were covered by the mobile clinics, how many people were tested for 4 types of infections. And in 2020, we're supposed to have a decline related to lockdown and some bans and just some curbing of some activities due to the pandemic. And the local press tried to persuade people that you'd rather not go to the medical clinic or outpatient clinic at the times of pandemic. But within the 2 months period, this trend somehow faded out, and the people do not say no to the medical assistance, especially tests are provided comprehensively with other services. As to COVID, we had to impose the anti-epidemic mode. In our mobile clinic, we had some special disinfectants, and we also used a series of tests. And additionally, we supplied the personnel with the PPE as well as patients, and it was done within the framework of our program and also partially at the expense of the budget. And also, it was provided by the hospitals, outpatient clinics. And the informational material for the patients was also disseminated in Tajikistan. And thus, we've managed to create some pertinent conditions for mobile clinics to go on working. And this is the prime information which I wanted to highlight. And indeed, we highly evaluated the role of the mobile clinics for the system of healthcare, and we will find some follow-up of this endeavor in other projects of ours, and it is supported by the European Fund for Stabilization and Development, and 4 medical modules will be involved in that project, and therefore we will provide the full-fledged preventive medical examination and also overall medical examination as well.
This experience is truly positive, and hopefully it will not finish when we complete our project. It was a pleasure to see the experts who are working in these clinics. We have finalized our agenda, and now we have several minutes for a Q&A session. And dear colleagues, you may now ask your questions to the speakers. Are there any questions? Okay. Let me address again. I don't know.
В городе Москве или? А, к вам?
Again, I don't know. As for this program, we are now implementing the third phase of the program. Maybe it will be prolonged. This issue was discussed at the coordination committee. There will be some interdepartmental consultations between the Ministry of Foreign Affairs, the Ministry of Finance, Rospotrebnadzor, and the Department of Health. They will decide whether this program will be extended or not. Still, we need the requests from other countries, and they were enumerated today. All the countries, 4 countries were represented, and all of them expressed their willingness to extend this program. This activity of mobile units and clinics is beneficial. People are going to extend the coverage by extra mobile clinics. It was said by the representative of Tajikistan that only 70% of the population of hard-to-reach regions may be covered, and 30% cannot be achieved because these districts are really remote. They are far from mobile clinics, and 1 or 2 mobile clinics are required in Tajikistan. Hopefully, this issue will be reviewed in a positive way. And we also have the last question. Maybe any questions? No questions? Thank you very much. Thank you, dear speakers, for your great presentations. Thank you, dear participants of our conference. There are many of you who are listening to us online and offline. See you in other sessions. Thank you very much. Thank you very much. Goodbye. Thank you. Thank you.
Я очень...
Как время-то быстро проходит на таких мероприятиях? Честно говоря, да, абсолютно. Тебя там не украдут? Никто не обидит? Я думаю, никто не... Ну, пусть попробует. Да. А то прямо слезы ведь сразу. Ну, вот ты расстраиваешься, Настя. Ну, нельзя так. Ну, что ты хотела, чтобы эта дурочка выспела и тебя тоже? Ну, что ты хотела? Ну, вот подумай сама. Ну, да, чтобы Крис еще посмотрел. Да, это смешно. Да. А мне прям это надо. Да. Да, я бы сделала точно так же, как и она. Если бы были ненормальным человеком. Ну, естественно, поэтому что сразу расстраиваться? Ну да, ну просто я говорю, как люди себя ведут в школе. Ну серьезно, это понятно. Там в советском классе мы тоже свои истории рассказывают. Там детям 15-16 лет. Ну тут да, тут оправдано. Ну что же, 37. Да. Вот, понимаешь, я сегодня тоже на нее посмотрела таким странным взором. Господи, вот что она из себя пыжит? Ну да. Ну смешно. Ну что на нее просто смотреть? Конференция, кстати, есть онлайн в открытом доступе. Надеюсь, что вы не будете меня послушивать. Потом делать нечего, да? Еще одно. А то я буду кидаться, и нет. Хорошо. Да, конечно. Вот. Да, ты... А чего ты боишься иностранцев? Нет, потом уже как-то нормально. Я что-то в первый момент все поможет. Да. Нормальные все. Ну, ты видишь, я слово все равно не перевожу. Когда эти речи надо как-то реагировать. Это все-таки, знаете, не глубокая медицина, как мы тогда с Ритой говорили, да? А их, по-моему, больше и нет. По-моему, в этой секции. Знаете, что-нибудь попей, поешь? Я думаю, да, может, даже чуть-чуть сладкого возьму, потому что... Нет, а какие-то были хорошие печенюшки. Ничего же не будет, что килограмм. Ой. Да. Вот, вот. Все-таки сложное мы создание, девочки, если вот так вот поближе пообщаться.
Ох, а некоторые девочки, ну вообще,
Да.
ну вообще, вот, это горе от ума, это от перфекционизма. Исключительно.
Ладно, вам точно ничего не нужно, да, Сергей?
Нет, это моя. Я там наелась, у меня еще осталось кое-что.
Да, я
Я
мало
сейчас
съела, да.
в клинику пойду, ты сразу занервничала, переживала, все побросала. А я еще еду на каторгу к 7 часам.
А как по части чего?
Ну, я каждый год делаю. Там мышцы, суставы, эти мозги, сосуды. Это как профилактика. Да, и я вот 1,5 года с пандемией пропустила, и сейчас вот я, ты знаешь, никак я шишку сделала, еще 4.
10, да, сеансов?
Надо 10.
А это в частной клинике?
Ну, наши, да, покажу.
Да и тоже, я понимаю, да, вот это?
Клиника дорогая, и лекарственная цена покупать.
Ну, я уже там много лет, того стоит, поэтому, да.
Да, надо выбирать эти
Молодого человека по врачам никак еще?
Да, я его в свое время все заказывала.
А зубы что у него там вы говорили?
Знаю, я все время его говорю, да, потому что на следующей неделе выберитесь.
Выберитесь, пожалуйста, потому что мне это не радует. Да. Хоть он об этом не знает, но меня это все равно не радует.
Ну как, у него зубы-то все помененные. У него вот один, у него полностью рот поменен. Но там у него что-то с костью не нравится.
А у вас есть хороший врач, который вот этим занимается?
Экспримы пишет.
Мне он тоже писал по поводу какой-то конференции по дыхательной системе, по легким. Что-то. Там нужно было тест пройти, я не успела, потому что было другое интересно. Ну ладно.
Ну иди.
Да.
информацию, как мы с ними занимаемся. Часть идет сокращенные занятия, часть сдвоенные. Я могу только сказать примерно, это будет после праздника. Нет, как раз в праздники будем заниматься, как раз будем. Как раз в праздники... Ирина Львовна, мы с вами это обсуждали раз 100 или 200. Да, вы пока ничего сейчас в программе не отметите. Теоретически, вы можете отметить все в программе до 30-го, пожалуйста, как оно идет. Но мы это выработаем целыми днями только к концу, вот, после праздника. Нет, ну звонить им надо по-любому. Они в воскресенье занимались с Еленой Евгеньевной. Ну, там это Крючкова с Буданцевым. Вот, Климова-то она либо пойдет в следующую группу, либо она присоединится к празднику. Мы еще это не решили с ней, она сама нам скажет. Вот, но она обещала по-любому оплатить. Но я знаю, что у нее сейчас в Москве проект серьезный, и она до 27-го там занята под кругоходный проект. Но она говорит, что прилично, я думаю, что она что сказала, то и сделала. Там сложнее с Буданцевым, да, как он там, да, как он такой у нас человек непростой. Вот. Да, вам тоже спасибо. Поэтому пока мы вам, видите, рады бы, на следующей неделе очень напрягает эта ситуация, поверьте. Да, но мы ничего не можем сделать. Да. Пока так вот. Хорошо, договорились. Всего доброго.
Да, это я.
Вот так интересно.
Ой, я взяла пару печенюшек и чай. Там стоят эти Ксения Розова, Аня и Макс. С Максом не стала подходить, еще с вами.
Ну да.
Да.
Угу. Ну да. Он даже не поздоровался.
Угу.
Да, вот. Все сюда.
Тоже, конечно, сплетня.
Угу. Ты должна быть к этому готова.
Да. Не я должна здороваться, мужчина. Да. Хотя в этом я сомневаюсь. Да, по факту.
Настя, вот если будешь так на все это реагировать, то здоровье ментального просто не хватит. Ну что это вообще такое? Ну ты не обязана всем нравиться. Я же не червонец всем нравится.
Ну вот как-то есть люди, понимаете, культурные, которым даже кто-то не нравится,
Вот
они не показывают.
общайся с ними. А с такими точно так же надо общаться, точнее не общаться. Угу. Ну, сколько нравится. Я же тоже боялась.
Я все. Да, что.
Что у нас там завтра какие-то иностранцы, по-моему, будет количество?
Нет.
Или только сегодня?
Нет, сегодня.
Да?
Завтра есть, но нам что, 2 что ли?
А они, по-моему, это ведут сюда?
Они, да, как председатель.
Да, да.
В Уфе у нас даже, я помню, на одной из секций был русскоговорящий модератор. Какой-то турок, что ли. Да.
Ну, приятно.
По-разному. Но в большинстве случаев, да.
Ну, сирийц тоже был не подарок. Тоже что-то поднаписано число.
Да.
Говорил одно и то же.
Я что-то там даже за ним записала про выражение.
Тебе надо меня в кабине сфоткать.
Точно.
Смотрела?
Точно.
Да. Так, сейчас я надену. Зажгу. Сделаю вид, что...
Оттуда, да?
Ты почти покрыть.
Здесь?
Ну, я не знаю, я не люблю тут.
Ага, я тоже.
Ну, я тебя из своей кабины.
Наверное. Ага.
Да, попробуй.
Так, вас видно, хорошо.
Ну все.
Я по-разному, и в портретном режиме, и в каком-то там еще.
Так. Что именно?
Да, уже работает.
А,
Ложусь сегодня рано. открытые за рубежа, что нам интересно, и пусть это наоборот выставляется. Это образец лучшего перевода, который все. Ошибки такие. На тот момент вообще не очень большой народ, который повторит. Сейчас у них там свои школы, академии переводят. А так ты вообще не был никого.
Но потом он это, он, мне кажется, как-то лопнул его даже его отношения. Лучше, да.
Ну, он такой.
Один раз он написал какие-то словари, что он всего весь карантин написывает словарь словаря на каком-то языке, а он вот шагом это был собственно говоря. Вы меня простите, а вы не правда мне рассказываете женщина.
Ну да, но страдает, он не понимает, как он делает.
Да. Он очень понравился, мне понравилось, Анжамал, Париж, которая сейчас в Казахстане, ну, вот она оттуда, она очень добрый человек, вернулась домой. Он ее добавил в Казани, потому что он написал, что готовит не очень. У нее вообще родной язык, и казахский тоже почти родной. Вот, но она не в кабине пока работает. Вот, и он ее добавил в язык, ну, видимо, ко всем добавляется. Ой, ну, смотри, ну, какой он умный, какой он умный.
А мне как раз не тему. И или народ в чате что-то там нет, наверное, в Фейсбуке где-то выставили. И народ пошел. Там, по-моему, Даша, как всегда, влезла с комментами.
Ну да. Главное, что как переводишь, клиент может что-то не заметить, но ты не исправляй. Ну да, я
Но по сравнению с этим можно гораздо привлечь.
Нет, это выставляет. Ну, она старается. Она не это в компании,
Нет, просто я вчера вот у меня убирали. Я все дни
ну да.
Нет, я говорю, у меня там вообще ничего. Ну, вообще не молочки. Ну, просто. Вчера последний цифр так не было. Говорят, между прочим, я правильно услышала, на маске, там, маске был такой. Да, да. Вот, я не стала слушать, я выключила. Просто я как бы слышала так, я хочу сказать, план опыт. Я еще буду тебя слушать. А народ сказал, что вроде ничего даже прозвучало. Никто его не знает.
Ну я же понимала, когда я его даже привела в свой мир, но это так, я спрашиваю, народ будет доволен. Что бы он мне рассказывал, там, как выглядит, что?
Опять же, из другого мира.
Да. Не, ну 3 часа почти, то есть, конечно, договорились на 45 минут.
Да. убери из своего окружения токсичных людей. Никогда не думай, что не надо делать совершенно. Это очень саморазрушает и совершенно, главное, не добавляет.
Ксюша, которая живем сейчас, знаете, на планету Токсина?
Ну, суть в том, что ты мне показывала, как она для нас прегалась,
Хорошо, что она сама.
Я просто была уверена, что она как-то проявится, поскольку она сильнее, и она всех агрессив.
И она мне на самом деле очень много набирает, потому что, ну, вот это вот отношения, понятно, что они завтра закончатся, они будут появляться, ну, как это вообще не надо, всегда пыталась ее поддержать, даже если там у меня совсем нет времени, но какие-то неадекватные вспышки эмоций ни о чем. Из-за того, что я что-то сказала, что социуме, наверное, лучше держать эмоции, это ее же главное, в ответ на вопрос, что с ним не так. Все, когда все ты включила, я просто тоже довольно знаменитая, я их понимаю, мне это еще Саша говорил, но мне проще было легче. Вот со сколько я говорю, все равно.
Ну, главное, что ты так смотрела,
Да.
она же все-таки тоже как людей. Она же видела, что ты такая невозможная, маркетинг.
Наоборот, да. Я с ней максимально подумала. Главы нет, ну, надо как-то.
Ну, она тоже.
И она очень такая непоследовательная.
Она очень непоследовательная, очень такая однозначная по Я только его стилила, несколько раз, как она везде ее стиражировала, смотрела, вот это есть человек. И на это можно поймать,
Да, ты 4, а потом скажешь, вот какой крутой, и все, он цветет.
ну и эти девки-то тоже отчасти, что они это
Конечно, то, что она же одноматная, это ей мешает, что она уже всех знает. Даша запросила, я же не знаю, сколько там есть, еще 12 родителей, мне это вообще копейку я уже, честно говоря,
все-таки период.
Ой, у меня микрофон был включен. Да.
Что здесь написано?
А можно...
Да, обязательно.
Сам. То есть с микрофоном шевелиться и ну как тебе удобно? А мы будем просить коллег, наверное, послать. Вы же будете листать их? Слайд. Листать, клики есть. Берем.
Вон он за краю. Есть.
Good afternoon, dear colleagues. Let us start it. If you have some presentations, please come up here so that we could see you. Unless you come up, you will come up a little bit later. Let us start our session. I'm ONS Madoyan from Armenia, the Vice Director of the National Center of Infectious Diseases. I would like to express my gratitude to the organizers for granting me this session. I have a 20-year experience in the civil society and in public organizations, and I'm nostalgic about it. Our topic is the civil society in the era of COVID-19. I believe that it was shown that in order to combat the HIV pandemic and the COVID-19 pandemic, cooperation is of prime importance. I mean, the cooperation of public organizations and the civil society. Our speakers will share their valuable experience in this domain. Would like to change the order of the presentations. Vladimir Mayanovsky had an urgent need to leave us beforehand. Thus, let me put his presentation on the first place. Yes, it is a pleasure for me, because we started calling one another by patronymic. We have been working as a public institution, and it's an amiable public institution for many years. But although I cannot call you this way, can I switch on the presentation? As for the interaction with public institutions, let me indicate of the interaction with the public healthcare institutions, which can be achieved by cooperation. There is a social bridge center, which is now functioning in Moscow. Here is the history background. The Social and Information Project Bridge, which is an information center, has been working on the basis of the second infectious hospital number 2 and Moscow AIDS Center. It has been existing since 2009, and it was allocated free of charge. Our counselors, our workers, volunteers, and activists are located there. this project is being implemented under the guidance of the regional public institution of cooperation to people who are living with HIV and AIDS. Which services do we actually provide? We consult on adherence to ART treatment, and our priority is the following. All the counselors working in the AIDS center are living with HIV. They have the experience in this domain. They receive this ARVT treatment. Here are the examples of people who are on treatment. And these examples positively affect the motivation of other patients to start treatment. We work at the request of the customers. We make them be aware of the transmission pathway and diagnosis of the virus and the RVT treatment, and they are also referred to other social services which have been functioning in Moscow. Also, they accompany them at testing to antibodies to HIV infections. They are referred to other social services. Not only the Moscow residents, but also the guests of the capital may get access to accompanying for HIV infection tests. We will conduct a preliminary consultation on the parity system, and then they will be in the cabinet of Moscow AIDS Center, and our infection doctor will also conduct this consultation and examination. The first kind of analysis is anonymous, and then the person receives results, and if he needs a certificate, he can get them by passport. If some problems emerge, we have this people register for it. If this person doesn't live in Moscow, we show him the algorithm of treatment regimen. We also carry out social accompanying of patients with disabilities. I mean, the supply of drugs. Patients with disabilities have difficulties while going to the social institutions. It is a true challenge. They provide them the service on the supply of drugs. If they are not located at home, if they are in the healthcare institutions, we also provide them with drugs. We do not only provide them to persons with disabilities. If we get a certificate and make a medical card, the person on rehabilitation can receive the drugs because they are delivered to this person who is not at home. We issue a certificate signed by the doctor and a special informed consent to the patients. Social accompanying of patients of Moscow City Center AIDS with disabilities, accompanying to medical organizations. I mean, the persons with disabilities of the first group, they are referred to AIDS Center for monitoring, for tests, in order to make them be treated, and then they are transported backwards. Another service is the following: those who refer to us, those who have problems, can be accompanied. We help others to hospitalize them. Thanks to our efforts, they communicate with doctors, and then they are referred to infectious diseases, to infectious hospitals. It may be related to persons without documents. The papers don't play any role. The number of the customers is the following: 1,383, and then this number increased. The number of consultations is 931. The number of people on drug delivery is 50. These figures do not change over years. 50 people are under our protection. We faced different financial difficulties in 2019. Still, this project is voluntary in some cases. We provide services to more people, but still 50 people are a constant number, which doesn't change. If this person dies or moves to another place, this place may be liberated. And persons in prevention institutions are the following. There are 42 people. COVID-19 is inevitable nowadays. Under the pandemic of coronavirus, the number of customers has increased. I mean, the customers who refer to social services, to the delivery of RRT, and accompanying to medical institutions. When nothing worked in April 2020, people aged over 65 could not even use public transport free of charge. They could be fined for being at that place. They were considered by our volunteers, and still our statistics do not include these people. We can see our loyal customers here. Thanks to our volunteers and our activists, people who were indifferent, we managed to implement this program. Despite the challenges of the pandemic, we tried to satisfy all the requests. We all did it. And some doctors referred to us saying that it was crucial. It is achievable because when we deal with the Bridge project, it functions under this center.
And if we talk about the second infection, hospital of the second Moscow Center of AIDS and the Narcological Center, that is a state-based entity. That's the one thing. And we have the foundation of Shogo there, also Mercy Fund, Embryo Positivная Oblast. So these are those NGOs and which are with us. Clients are different, requests are different, and due to the partnership network available, we actually readdress the clients upon the profile. If we are unable to do anything ourselves, if some hospitals are needed, we dispatch them to the narcological entity. And also the overwhelming majority of work is done by the volunteers. They do the bulk of work. And also, as a follow-up to COVID-19, this is one of our organizations, the Moscow Interregional Oblast Organization. And if you do remember, there was the special presidential grant allocated for COVID-19 combating project. And we, within 6 months, managed to acquire very significant indicators to providing social service, to disseminate PPEs, to support the patients onto special hospitals and outpatient clinics, also delivery of drugs and equipment, and quite a number of people contributed onto this particular effort, and also online, thanks to the efforts of our volunteers and employees. We have the Fund for Presidential Grants in 2017, and also the Committee for the Public Connections and the Youth Policy under the Mayor of Moscow supporting us. But even though we couldn't have money at certain periods, anyway, services are provided. And we think it's our great achievement, and we never had any interruption in our activities. And so we see our whereabouts. That's the central AIDS department, and we have an extra exit, and we have a standalone block, and we are more than happy to provide assistance to everybody. And actually, if you have any questions, you are welcome. Thank you for your presentation. That is a good example of cooperation of PPP. and actual NGOs and public structures are cooperating. You do not have to pay for rental fees and other fees. Dear colleagues, if you have any questions, you are welcome. I heard about volunteers, and some people have been working there for 15 years. How many volunteers are available? Maybe these are the same people who used to work with you for a number of years. Yes, indeed, we have 3 or 4 young girls. They were very highly motivated when I organized some learning activities in the university. And they said that they want to go to the hospital ward, the isolator, and it's HIV/AIDS aid they provide, and this is also a group of mutual assistance, and we have people always ready to help us. And thanks to that educational programs, we have the girls to be involved in that business and as volunteers, and 90% are those who are representatives of ours who already have HIV or AIDS, and we rendered assistance to them at a certain point of time, and now they do it on a reciprocal basis. Thank you so much. Sorry, the question cannot be heard. You organized in the course of lockdown the delivery of medications. You somehow streamlined this procedure. And how did you manage to do so? Yes, I understood your question. We, when the quarantine was administered, couldn't go anywhere. And the car was under the cameras, and you have to pay 5,000. These were my happiest days in Moscow. I'm a Moscow-born person, and I was happy to get these letters penalizing me. And all the passes were issued via Gosuslugi electronically, and those who were with us got the passes absolutely without any complications. What allowed us to deliver our aid and assistance, and we normally had calls from our patients. We always had the PPEs, and we didn't give any deliveries in person. We put everything in front of the closed door, all the parcels, and actually that was how we acted. They just electronically signed the mere case of delivery, and we had those people among our patients who had the identified COVID. They had to stay at home, having not a very severe form of COVID. And we actually had to communicate with them. And it's a good thing that we had a chance to move. And the majority of NGOs well, actually managed to do so amidst the pandemic. Any other questions? Thank you. I'm so sorry. It's force majeure. I was supposed to be the last speaker. Okay, I wish you all the best and success. I want you to take some of the souvenirs of ours. Some condoms, some other tools that comes from the organization UH. And now the floor is given to Vereshchagin Yuri. Yulia, sorry. Good afternoon, ladies and gentlemen. I represent the patients movement, patients control, and I'm going to dwell upon my project and how we provided drugs in the course of COVID's lockdown, and specifically for the foreigners. Due to the pandemic, thousands and thousands of people happened to be at the territory of foreign countries, and among them were HIV infected. And they were supposed to get the antivirus preparation drugs, and they were supposed to get this therapy. Being locked at the territory of other countries, they have become the hostage of this situation. And actually, nobody knew how these measures have to be administered, and nobody knew how long it will all last. And people were sometimes unable to purchase any medication of that sort. And this RV drugs are not available, OTC, and the patients were unable on a free basis to acquire this specific drugs. And so jointly with the non-commercial organizations, we addressed a number of companies with a request on the charitable donations, thus providing antiviral drugs for the foreigners held at the Church of the Russian Federation. 5 companies granted this aid to us, and this information was disseminated in the social network in some FEB groups, for example, dedicated to HIV. And they also got the information of that sort from the doctors of that patients staying in their own countries. It was all necessitated due to the fact that the prescription had to be issued for those specific drugs. And thanks to the efforts of HIV activists and the employers of international organizations, we've managed to work in that fashion while acquiring the prescription, and the monthly drug administering was provided, as well as the consultation of our physicians. In Russia, we do not have any type of combined drugs. Many patients are accustomed to that, and they had to replace some mono drugs. And thanks to the consultancy provided to that services, all of them got a detailed instruction and prescriptions as how to administer this or that drug. The project was initiated at the end of May and lasted till September, and the majority of requests arrived in May and June. Then the flow of requests somehow minimized later, but still till October we got those list of requests, and 449 people got that aid out of 19 countries, and the majority of those inquiries came from Ukraine, Moldova, Kyrgyzstan, and Armenia. And the first inquiries arrived at the very start of April, when the borders were closed, and the Patients Society and volunteers actually provided this aid at the very start, and 78 foreign-based citizens got this aid at this period of time. Those patients were disseminated all along Russia in 35 regions of Russia, just quite a vast geography, I should say. And the majority of messages came from Moscow and St. Petersburg, Tatarstan, and the Moscow Oblast. And it's also worthy to mention how we provided the aid beyond the territory of the Russian Federation. And it was LifeMe Plus treatment, and we rented equipment and medication to HIV positive people who were forced to stay beyond the borders of Russia. 232 people locked in 49 countries of the world managed to get this aid. And each of them were sponsored in terms of getting the therapy at the country of their location. And summing up, let me say that it was all due to our joint efforts, and we retained the health and safety of people having HIV. They managed to go on treating their disease, and it also minimized the risk of some complications and implications that of the opportunistic infections, which may occur due to the interval in the course of the treatment and the follow-up hospitalization. And I think we also contributed into the prevention of HIV, and the better contact with NGOs and other doctors were streamlined. And at the time of this painstaking period, we spared no effort as to organizing this work for the foreign-based people. And this aid just reached.
You. I believe that we have conducted great work. It is the work of the patient control, which is aimed at providing access to treatment. I personally would like to highlight that some of our patients were in Russia. They allowed us not to interrupt treatment. Many of us faced it. Thank you very much. I'm very happy, thank you. I would like to express my gratitude to your team and to your workers. Maybe any questions to Julia? What is happening to these patients right now? Are they on treatment? What do they face right now? People started opening borders in September, and people managed to have a chance to leave for their countries. People started opening borders in July, and there was a decline in these communications. In June, we received 150 messages, and there were 90 of them in July, and there were 40 of them, 40 flights in August. People started coming back to their countries for treatment. Some countries, such as Kyrgyzstan, managed to streamline the provision of drugs from Kyrgyzstan to Russia so that people could have a chance to save money for the flights because they became very expensive. The budget was also limited. We hope that the project would last till July because the borders had to be opened, but the measures were reinforced and we managed to prolong this project till the end of September. No one hoped that it would last for such a long time and the borders would be closed. Still, we succeeded in existing under such conditions. Thank you very much. Maybe some other questions? No questions? Dear colleagues, we also have 3 speakers. Do you have any information on them? Let us listen to one of our speakers via Zoom, and that's all. Tigran, here. We're delighted to see you. We're delighted to hear you. We're delighted to hear you. Could I talk? Are you watching the online broadcast? If you're watching the online broadcast, you can either switch it off or switch off the mic. We may start. That's great. I would like to invite Tigran via Zoom, the regional counselor of UNESCO on HIV and education in the domain of education in healthcare, discrimination of workers of education with HIV. Sorry for this delay, Tigran. The floor is yours. The preventive approach to discrimination, to prevention of discrimination of students with HIV. Good afternoon. Can you hear me? Yes, we can hear you. It's all right. Good afternoon, dear friends. Unfortunately, I cannot hear the presenter via Zoom. I would like to receive the feedback whether the participants hear me or not. Yes, we can hear you. It's all right. Maybe you'll send a message in the chat box to him. Yes. Hopefully you can hear me, and I'll keep my presentation. Thank you, the organizers of the event, for having me at this conference. It takes place in this hybrid format. I would like to join all of you in the World Trade Center. I'd like to see my acquaintances and my friends. We've just listened to interesting presentations of our colleagues about patient organizations who helped people with HIV in this challenging era when we first faced the lockdown and no one was aware of the actions they had to undertake. But the topic of my presentation is different. We have already covered this topic at the conference, at the plenary session, despite the fact that over 30 years have been after the pandemic, stigmatization and discrimination are a hurdle to people who can be tested and be treated. And overcoming the spread of HIV infection and the implications of HIV should be more effective. We have already found a lot of information on this virus. We are aware of the ways it spreads, but we are afraid of it. We have an unbiased attitude to those who are affected by this disease. Maybe you remember the American teenager who was Ryan White, who was diagnosed with HIV in 1961, and then he fought for his own rights and the rights of patients with HIV, for the opportunity to live at a normal life, to study at school, and to socialize with friends. Few facts were known about this infection. Some of them did not have any access to school. Still, he received the permission, although he had to move to another town where he started going to school. His health condition got worse, and he had to work at home. Many years later, due to these irrational fears, we still doubt, we hesitate. Occasionally, we read these facts in the press. People face the following situations. Schools or kindergartens may not allow some children to study at school or at the kindergartens. They face the choice. Sometimes they are compelled to leave school. Over these years, the situation has changed. If we even review the results of the All-Russian Representative Survey conducted in 2005 and 2018, we see that the public opinion has changed. Back in 2005, more than half of the respondents believed that it would be impossible to let their children study at schools where patients with HIV studied, but the proportion of these respondents decreased twice in 2018, and the proportion of those who understand that it would be hard for them to send their children to schools with HIV patients, they would be ready to do it. This happened in 2018, and the proportion of such people increased twice. Still, they understand that that is all right. This data inspire us, and our immense work is conducted by real heroes and activists who reveal their diagnosis, who socialize with others, who participate in different press events and help the society overcome these inexplicable fears and bias. We also contribute to this systematic activity conducted by the Department of Health and international agencies. It is aimed at creating the legal base for schools, other educational institutions. It is aimed at education and work of people living with HIV. 10 years ago, alongside with the International Organization of Labor, we issued the first guidance for Europe and Eastern Asia. This guidance stipulated why we did not have to be afraid of these people. We had to support the students and the workers with HIV. And national guidelines are now based on these guidelines. And they are recommended by the Ministry of Health in 2017, when we created another kind of guidelines for schools related to non-discrimination and prevention of bullying at school. We adjusted our practical recommendations, and they were alleviated. They handled all the issues which might emerge in the leaders and the students and the workers of educational institutions. Precautions were put forth, and these guidelines were disseminated across the whole country. It is still used in many regions. We got the feedback from Altai Krai and Chelyabinsk region. In 2018-2019, we used these recommendations for teachers, for headmasters, 8 centers from the regions which you can see on the screen: Chelyabinsk region, Irkutsk region, Ekaterinburg, Volgograd region, to name a few. We reviewed these guidelines. It was a special document devised by the Scientific and Practical Center aimed at treating HIV in pregnant women. Thanks to the support of Natalia Ladne, the AIDS Center, the representative Natalia Dementeva, and the Foundation of Strategic Initiatives, we managed to create this facilitated and handy guidelines for schools, colleges, institutions. People could understand how they had to act when teenagers or workers came to these institutions, if they are HIV infected. And if this fact is found out in educational institutions, these guidelines were recommended by the health department of the RF. And these guidelines comprise all the necessary pieces of information which are required by teachers, headmasters. There are answers to all the questions which students or parents may ask. Why is it safe when an HIV patient studies at school? How can HIV be transmitted? Why is it that important to comply with confidentiality? And how should people at school act if one of the patients or one of the students or one of the workers is diagnosed with HIV? How could they you communicate with the parents and the students in order to eliminate these fears? How could you respond to these questions, and how could you avoid these conflicts, providing the safety for all the workers and all the students in emergency situations? The precautions were reviewed, given the data stockpiled over these years. They were alleviated still. We can see the same data recommended for all the blood-transmitted infections. They're simple. They may be used at any school. There is no need in carrying out trainings. Still, neither teachers nor students should forget about it. People should not overreact and panic in these cases. The guidelines include a detailed algorithm of actions for different situations. If someone fights with other people, if someone has a bruise or a laceration, they also discussed how the first aid could be provided. Prevention of AIDS is topical for teachers, especially in the context of the schools where HIV patients are located. We selected special key points for their organizations for a short training for both children and teachers and parents. These guidelines were supported by the healthcare department. A brief webinar was organized all over the country. It is now widely used. It is also topical for AIDS center workers. It is a handy resource when they are invited to schools in order to carry out practical conversations or preventive conversations, or when some conflicts emerge. It is of universal nature. It may be downloaded on the website of our institution. You can see the link in the lower part of the screen, but the key problem, which I have already mentioned, is irrational fear. Sometimes they are inevitable, and these conversations do not impact the situation. It depends on the mastery and the skills of the teachers or the doctors who will be invited to schools. These doctors or teachers should tell others that HIV children are not dangerous for other school children. It's kind of arts, mastery of parents or teachers or doctors. And we also referred to cinematographic arts when we supported the creation of this film. This film tells the story of a girl with HIV. She studies at school and she faces bullying. This emotional impact on the viewers is also visible. And not all teachers and medical workers can contribute to it. This film was approved at many international festivals. You can watch it free of charge in the online cinema. Many kinds of media mentioned that it should be shown at all the schools, to all the teachers, to all the students, and it can also be used as a key tool of enlightenment and education. Let me show this bright image with our last product. It is aimed at helping teachers and communicating with young people online or at the audience. Health, relations, love, and HIV infections may be discussed in the course of these conversations. And the Goodwill Ambassador of UNAIDS participated in these films, and they are now in English, in Russian, and they are placed on the educational website of Kyrgyzstan. They're aimed at all the countries of Eastern Europe and Central Asia, and this website may also be used when we face fear, discrimination, like when we lack attention, or when we would like to carry out preventive classes with students. That's what I would like to share with you. Thank you for the work done by public organizations. You really help the HIV patients, and we also contribute to it, and we would like to avoid discrimination and biased relations. Thank you very much.
Thank you, Tigran Albertovich. Thank you so much. Can you hear us? Can you hear us? If there are any questions, will he follow? Maybe you may write your question in the chat. Yeah, are there any? Please formulate them briefly. I can hear you only via broadcasting. Are there any questions? Thank you. Tigran, can you see us? Can you follow us? Thank you. Thank you so much. Okay, let's announce the next speaker. Taisha Lilia Khatovna, and she will be online with us via Zoom. Please switch on her presentation. Once again, thank you so much. Lilia, hello. Can you hear us? Lilia? Can you hear us? we have again a communication problem. Maybe we... Good afternoon, dear colleagues. I think you hear me, as I do not have any feedback. And unfortunately, I have to speak just one way. And if you hear me, I will get started. Good afternoon. My name is Lilia Tailsheva. I'm the director of NGO organization, New Age. I am the doctor of medical science, the expert of the public chamber of the Russian Federation, the Agency for Strategic Initiatives. And my story today is about innovations in HIV prevention. When you may get a variety of results using several efforts, and the organization of ours may support thousands and thousands of people and change the world. And we have to undergo some transformation since 2012. We have become an initiator for the prevention of HIV as a part of the great effort supported by the executive bodies, and HIV AIDS was a standalone program as well. And we've been cooperating with sports organizations all over the world. And when we organized our new event with the idea to prevent HIV/AIDS for the university, we didn't understand our clear mission. But in the midst of major events, we have quite a congregation of people in one area, and all the positive ideas had to be promoted. And this mass-scale event may also change the attitude of the society to HIV and socially responsible behavior. And thus we started organizing the series of very successful projects, thus opposing HIV. In the course of the summer university in Kazan, the aquatic sports championship, and then 2017 events, the President's Cup, and the Secretary General of FIFA applauded our initiative. And when such person comes to your site and expresses his appreciation over your efforts, that's a real great praise and bonus to us. And in partnership with UNAIDS, with the federal and regional authorities, we got a very high evaluation of our involvement. And the Olympic Committee of the Russian Federation and other NGOs also spoke high of our work in the long run. Test for Victory, that's a brand new project which is organized by the Confederation in 2017, and it was a part of the large social initiative in Kazan when we had WorldSkills in Kazan to organize. And here you see some vivid exhibits as to how we were visited by VIPs and athletes and stars, but it is not a number one thing to mention, but our projects do change the mentality and track of thought of our people. And about 8,000 volunteers took part in that, and express tests were also mass scale. And we covered via our information meteorology system the massive array of audience. It was about 6 million people altogether. Test for victory. It means that you manage to struggle your fear, struggle other fears and deficiencies of yours. And the next project, Test for Victory, was supported by the presidential grant, and it has become a daily basis project. And we started operating at the Privolzhsk Federal Okrug and in 9 regions of the Russian Federation and 3 key locations like Almetievsk, Kazan, and all in the Republic of Tatarstan, and also Bugulma. And I guess that this project will definitely provide on a free of charge basis some prevention of various diseases, especially HIV/AIDS. And also Ombudsman for the Human Rights will also support our project accordingly. And the project is R&D based. And what we're seeing here is the table which says that 37%, 35, 17 was it was all the efficiency of our tests and of we used all the available tools in order to implement this project for victory in terms of tests and other activities. We are supposed to involve 60,000 people, plus express tests for HIV. And we started providing all these available services for the general audience. And the tester mobile is traveling all along the regions on a daily basis. And we used to think that we would be testing people more in the major cities and towns. But once we come to rural areas and other small-sized settlements, I see that those tests are in a very high demand. And this is the statistics of today. And for us, it's a very valuable experience. What is the peculiarity of the project? And the Ombudsman for the Human Rights supports us in providing the full scale of services on a full cycle basis. And thus we address all the challenges of today, and up to the problem is revealed and up to the problem is resolved, we support the entire process. And really, we're going to work with the social network, with social media, and various venues and sites. And it will be, for example, the charitable program in VKontakte, and thus covering quite a number of people. That's the largest project in Russia as to the human rights exercise. And when the Presidential Grants Fund was originated in 2018, we used to say that large-scale projects are necessitated and the major companies are to be involved in that project. But as of today, we do realize that our organization may be given grants of various types, and St. Petersburg also has another interesting project based on this system of grants. And definitely, I really have to comment on that slide. And we have the socially responsible organizations to deal with HIV and AIDS. And it couldn't be done without the team which we have. And it's 24/7 program work. And actually, they managed to cover 7,000 kilometers, covering 600 locations, and nobody said no to that particular initiative. And program director, Mrs. Burenkova, Gulnara Fizyanikova, so these are very promising people, and you may put a question to them. And my team has their own stories. They actually arrived as volunteers. Now they work as coordinators. And actually they teach other people to learn.
Invariably, our experience shows that our resources and the potential of the partners are beneficial for us. When NGOs and the representatives of show business and famous sportsmen unite, we receive this synergetic effect when we change our attitude to it. And there is one illustrative example when we started working on public testing, and the representatives of the media came here. People were reluctant to comment on it when there were some queues for the test, and now people are eager to make the videos of them in the rear projection, and no one of these people were eager to hide their faces because it is okay to undergo tests. In conclusion, let me show the following issue. For the strategy on prevention of the spread of HIV infection in Russia, this document plays a great role in the civil society. This year demonstrated us that Rospotrebnadzor and the President of Russia supported the role of the civil society at the regional and federal levels. Many NGOs face misunderstanding or even prevention to their work. When the head of the Epidemiological Center says that he's not aware of the fact that they're doing special work on HIV prevention, some resources of healthcare were also modified. The programs of supporting voluntary groups did not have any regional funding, thus they suffered. We're interested in the territorial structure of Rospotrebnadzor, and reports are provided. There is no real support and assistance. Another example is the following. Last year, we worked with more than 4,000 people from vulnerable groups of people, and only 63 people of them were HIV positive. And healthcare institutions helped them. Our case is not single nowadays. As far as I know, the situation in other regions is not much better. And NGOs are not the field of interest for everyone. Not each AIDS center is interested in NGO, and not all these centers cooperate with NGOs for many years. It is a little bit strange that our project was supported by about their activity. Thank you, and sorry for being so emotional. And to sum up, let me highlight that our health is our top priority. Being a medical doctor, I would like to tell you that the scenario of the HIV infection is similar to the scenario of COVID-19, but it is more prolonged. And the name of our team, Task to Win, is symbolic. Hopefully this year we will be able to combat HIV and COVID-19. Thank you for your attention. Here you can see my contact data and my email. You may send me a message because I cannot hear the questions. The audience, there are still 2 workers who may answer these questions. Thank you. Thank you, Lilia Akatova. Thank you for your gorgeous presentation. Still, you cannot hear us, can you? If you have some questions, you may ask them, and our colleagues will be able to answer them. We may put them forth in the end, and then we will tackle these issues. There are also some brochures, some leaflets, which contain the key information. We can only hear you via the broadcast. You may just take these brochures, the key information. There are also our bracelets. Any questions? No questions. Now let us address Alexander Mordovin from Moldova. He will represent the initiative of the International Federation of the Communities of the Red Cross and the Red Crescents. He will draw upon solving the problem of equal access to health care in the context of HIV infection for the most vulnerable groups of the population. Neither will he hear us. Could you please start it? Yes, I will dwell upon it right now.
Добрый день.
Good afternoon, dear colleagues. I hope that you can hear me. Can you hear me? Yes, we can hear you. Okay, now let me start. I can also hear myself in the broadcast. Dear colleagues, good afternoon. First and foremost, let me introduce myself. I am the vice head of the regional representation of the International Federation of the Society of Red Cross and Red Crescent in Russia, Belarus, and Moldova. Let me outline the activity of my organization, but you should know that the International Federation of the Red Cross and the Red Crescent is the largest humanitarian organization in the world. It operates in over 190 countries of the world, and it unites the societies of the Red Cross and the Red Crescent. We have been mobilizing the communities for over 100 years. Thanks to our activity, we protect people who are outside the social system. We also provide psychological support and social support. And our organization has sufficient potential for tackling healthcare problems in acute situations. And we also increase the feasibility of and the vital aspects of those who are combating the HIV infection. We also dwell upon social protection. This experience may be beneficial for expediting the events of HIV prevention. We need it in order to combat the HIV and AIDS epidemic in 2030. The community of the Red Cross and the Red Crescent is vital in our region. We raise the awareness of the migrants, and we provide them with access to healthcare services, and the vulnerable categories of this population can also participate in it. And let me dwell upon this issue. Maybe my presentation will not be in line with the practical context. But our work and our key topic mean the contribution to our activity. Hopefully the people who need help will get it. And the representatives of the civil society working with the people in need will also benefit from it. It has already been mentioned at the conference that our region, EECA, keeps the highest speed of HIV spread in the region. Epidemiological processes impact one another, and sometimes the legal basis is not agreed upon, and countries combat the HIV epidemic in isolation. Thus, it affects new groups of the society. When we solve these comprehensive issues related to HIV infection, we still have lots of barriers, such as medical, social, educational barriers, while combating the infections. The hurdles are the following: stigmatization and discrimination. And this barrier exists when people are tested for HIV. Sometimes people are not granted access to it. The access to treatment is insufficient. In some CIS countries, only 50% of people receive the adequate IRVT and the corresponding medical care. Thus, the interruption of treatment or absence of drugs may deteriorate someone's health, and it may also negatively impact the HIV epidemic with certain consequences. It is an important factor of combating the HIV, especially in the countries with labor migrants, when treatment is provided to HIV patients in these countries. The following question arises. This norm aimed at these people should be included. I mean, the norm, which is not that epidemiologically efficient and effective, but it is a barrier. People with HIV should have the right to be in other countries, and it unfortunately contributes to stigmatization of migrants. The key barriers to organizing the treatment and expanding the access to healthcare are the following. There are some legal barriers in these countries, and there is also a problem of financial support of HIV patients in other countries. This problem has various aspects, and we need a comprehensive approach in order to solve it. It should be aimed at mobilization of efforts of state agencies and organization of the civil society. One of these examples is reviewing the legal basis of the international organizations and the organizations of the civil societies and the public organizations. The review should be prepared for the legal basis in the countries with these patients. It was conducted by the Red Cross and the Red Crescents jointly with the International Assembly of CIS countries, we take into account the mobility of the population, and there is no aspect which will be a review of the legal basis in the region. And these measures were topical. This document allowed us to provide the full-scale patterns of the legislation of in the CIS countries, the accessibility to comprehensive support should be provided in these countries. This review became a prerequisite for developing so-called special laws for CIS countries aimed at equal access to the services aimed at prevention of and the treatment of HIV in the CIS countries. We have analyzed the legislation and the coordinated efforts of the countries aimed at combating CIS, and joint control may increase the effectiveness of our actions aimed at providing access to treatment. This would allow us to control and to forecast the consequences of the epidemic in these countries, and this would decline the mortality associated with HIV, as well as the morbidity. This legal basis would allow us to find optimal political solutions, and it will be based on the legislation of the CIS countries. And this would allow us to effectuate the effective to the programs aimed at combating the epidemic. The chance to providing medical assistance to all the categories of the population in the CIS should be notched up in the legislation. In 2019, we initiated the following aspect. The International Assembly of the CIS countries decided to devise this law aimed at combating HIV epidemic and equal access to diagnosis of HIV and AIDS in the CIS countries. This initiative was approved in the beginning. People started initiating this project in 2019. Still, we understood that we were a large international agency. Still, we were not able to introduce these legal initiatives without the participation of the representatives of the civil society. A key stage while drafting this legal draft became the forum of the representatives of the civil society in the CIS countries. It took place in 2019 in November in Moscow. Over 20 agencies of 20 countries were involved in it, and I also mean the community of the Red Cross and the Red Crescents. There were also some service organizations and the special organizations aimed working in these countries. The LNS, the facilitator, you also participated in this event. We formulated the key principles during this meeting, as well as the key approaches and the key barriers. And we have to eradicate these barriers by means of the new law. Eventually, the legal draft was devised. Regrettably, the process of enacting this law is time-consuming. Still, in November 2020, we managed to firstly listen to this law in the Interparliamentary Assembly of the CIS countries, and then it was sent to the parliaments of the CIS countries in order so that they could amend it or listen to some comments. The key aim of devising this law is harmonization of the national legislation of the CIS countries, providing equal access to HIV prevention and treatment. This law would rest on following the rights of the citizens in the CIS countries, in the
and the public guarantees. And the priority is that the patient may be provided with the social and medical aid in case they experience a loss of health. Also, the responsibility of the executive bodies for the safety and medical care, the quality of it, the responsibility not to deny any person, and failure to comply with the medical secret. And as I've mentioned already, within three months, we managed to approve it after the first hearing at the Standing Commission on the Human Rights. And from December to March, this bill has to undergo some expert review from the CIS Parliament. So we got the comments from everybody, and the majority were quite positive as to that bill's contents. And tomorrow, the Standing Commission on the Social Issues and Human Rights is going to have the second hearing of that draft law. And I do hope that it will be successful and approved further. And afterwards, we will get it prepared for its adoption at the autumn session for CIS countries. If the law is approved by the interparliamentary group, will not be subject to the 100% approval by the CIS countries, but proceeding from the fact that it has underwent certain hearings at the national parliaments and line ministries and agencies of all the CIS countries, we do suppose that this law will give us a very high level of adequacy. And I do mean that we're supposed to have the promotion for the Red Cross and the Red Crescent, and those who oppose HIV infection, and that is a new instrument which will be aptly used by us in promoting the advocacy and political dialogue at the level of all decision makers in both countries and in various countries, and thus we may amend various national CIS laws. And those harmonizing them and making them more efficient, attaining the goals of the global strategy for HIV. Thank you very much for your kind attention, and if there are any questions, I'll be more than happy to answer them. Thank you. Thank you, Alexander Stanislavovich. Yes, are there any questions from the audience? I can't hear the audience. Sorry to say that. Not so far, and I would like to request that the organizers would write a few words of gratitude to everybody. Thank you, Alexander. Thank you. Thank you. Dear colleagues, we followed quite a number of presentations dedicated to the topicality of PPP and communications with NGO And we know much about stigma and discrimination and how to oppose it. We heard about various attitudes as how to improve the access to HIV treatment. And I think this session gave us some new impetus, some new ideas as how to work further. And thus we will really bear fruit and find something beneficial for us all. Thank you once again for your kind attention.
Еле коям Дина Барсона. Я говорю, вечером цена на презерватив выручит. Нет, но